height.
month.
So usually it will be
Just
at the
came
site of the
around to
tick
say
height.
Happy
So it will
New
be
Month. I'm
symmetric here. Okay.
studying and I want to say Happy New Month.
Next topic is erythrasma. Erythrasma. The only way that you can get asked about that is picture. So is generally asymptomatic, flat, slightly scaly, pink or brown rash found in the groin or axilla, caused due to overgrowth of the Dipteroid Corynebacterium. Sometime examination with Wood's light reveal coral red fluorescence. Topical antifungal meconazole can help. Sometimes topical antibacterial can help. In severe condition, you can prescribe oral erythromycin. So this is how it looks like, okay? Erythrasma. And definitely you should not get confused between that and the acanthosis nigricans, okay? So this is how it appears. Usually appear in the axilla or the groin, okay?
So erythema generally asymptomatic, flat, slightly scaly, pink or brown, found in the groin and as like caused by overweight, overgrowth of diphtheroid choriobattery, wood light, coral red fluorescence. Topical miconazole antibiotics are usually effective. Oral erythromycin is for extensive infection.
Next topic is, okay, before going to the next topic, because it's not covered here, this is picture of something called erysipelas. Erysipelas is skin infection, okay? Erysipelas is skin infection and management is a little bit closer to the impetigo and cellulitis, okay? So here if we went to the summary of the antibiotic skin management, so you can have cold sores, no, we are going for eczema, no, impetigo. So here is the impetigo. So erysipelas come with the cellulitis, okay? Where is the cellulitis? Yeah, cellulitis and erysipelas. So management of erysipelas is similar to the cellulitis, okay? So if you get asked about the management, you will get the guidance from the cellulitis. So flucloxacillin is the first line, and here are the
Hello,
okay? So
Dr.
next,
Omar,
welcome and
yeah,
happy new
uh,
month.
like the resource that you have just shown with
If
the
you're here,
antibiotic
you're
guideline,
welcome
is
and
it a
happy new
NICE
month.
guideline or it's a local guideline?
this is an
Hi
NHS
everyone,
guideline. So this is
welcome,
the nice
happy
one,
new
okay?
month.
As
How
you can
was
see
your
here,
day?
all the summary.
Happy Sunday. Did you go to
All the
church?
visual summary from the NICE is included
Let
in
me know
this
how your day
guideline.
was,
Okay, so this is
guys.
not local one. This is general universal one. This is the NICE guidelines,
I'm
Public Health of
studying. Do
England
you want to
summary of
join
antimicrobial
me?
guidance that should be applied
Thank
for.
you.
Okay, so this one is
Thank
not
you.
something local. This is something.
Right, right. This will be extremely helpful
Hello,
in the future setting.
guys.
Okay.
Yeah, definitely.
You're welcome. Happy
When I shared
Sunday.
that for the
Thank you
first
for
time, I
joining
told
me
my audio
tonight.
colleague, you have to have this one on your desktop and you
Hello.
cannot
Hey,
work with
DM.
it.
Hey, Tessa. You guys are
Okay, so
welcome. Happy Sunday.
let's
Happy new
continue. Okay.
month.
Somebody asking how to distinguish between erythrasma from acanthosis. There is no
Hello,
confusion between both of
Tessa.
them. Acanthosis
Ravindra.
nigricans
Hello.
is just
Hola,
black
hola.
discoloration and it will not be
Yeah, how was your
patch like the
Sunday? How
erythrasma. Let's
was
take a look on both of them and you
Yeah,
can
like a
analyze the
joke. We
difference.
already in
So
December and I'm so
patch,
excited.
it's big patch,
How are
continuous
you
patch
guys?
like that. Okay.
Well, I'm a
Um,
medical doctor, so I'm
Acanthosis
studying
nigricans, it's
skin
not patch, it's
diseases.
some
I'm studying illnesses
black
that can affect the
discoloration. As you can see,
skin.
there is some break between both of them. It's
Do
not
you know what is
continuous
called
patch like the
acanthosis
other one. Okay.
nigricans? Do you know what that is?
So here is pigmentation, dark
So
brown
I'm
pigmentation. The
studying.
other
That's
one
what
is
I'm just
patch, one
studying,
big patch. Okay.
Mm. I'm studying some
So
skin
where do we go?
rashes.
So erysipelas management same
Mm.
as the cellulitis, and
Hello,
definitely
Digibot.
presentation will be
Hello.
similar to cellulitis. So you will have
So
like a
acanthosis
picture,
nigricans is a
patient
kind of a
face
skin lesion
having
that normally
patch,
appear in the
dusty red,
armpit,
and
and
description will
it
be hot
affects
to
those who
touch,
are a
tender,
bit on the very
painful.
big
So all
side.
of that will give you
But do you know the one that is called thank you,
more clues that it's
Radhavandra?
erysipelas.
Oh,
Okay.
I'm so
So,
perfect. That's
but
so
you can
lovely
get
of you.
confused
Thank you.
on what
Do you
other
know the
other.
one that is
No, it
called
doesn't need.
do you know
Management
the
is
one that
similar
is called
to the
cellulitis?
cellulitis. It depends on the severity. Okay. So
Cellulitis
you
is
will treat with antibiotic if patient is
when
systemically
you get
unwell. You will admit.
infection
So
in
admission
the
is not
fat
the first
tissues under
option.
your
You will
skin.
use your clinical judgment to decide if patient need to be admitted or not.
Big ear
Depends
rashes.
where is the infection on the face
You
exactly.
can say that
So for example, I
again,
tell you
Jay.
my own
So there's another one. I don't know
practice. So, for
if you're
example,
a
you have
male,
something called dangerous
there are
triangle on the
rashes that
face.
could
You know this
appear in the
triangle here.
private of the males.
This
You
is
know
called
that,
dangerous
right?
triangle.
In the
So, if, for
pink
example,
down
like this one,
below,
it's there is
when you
some
have
periorbital
unprotected cells,
roughness
you could have
affecting the
rashes
nose.
there,
This guy definitely, I will admit, I will not
and you need
risk
to treat them
managing
so
this guy.
you
But
don't get
one lady
serious.
like that, she has spared
Mm-hmm.
dangerous triangle. There is no
Where am I
periorbital
from? I'm
infection
from
or toughness
Nigeria,
or
and you, where are
problem
you
that
from,
would affect
DM?
the orbit. So I will manage
I'm
at
from
home
Nigeria. I
and
live in
sitting
the
in the patient.
United
So
Kingdom.
management will depend on the severity, how it looks
What
like,
about you? Where are
but
you from?
definitely erysipelas guidance for management is same as cellulitis. Okay, so as you are managing cellulitis, you will manage the erysipelas. Okay,
So there's another one that is called the Receptula, and that
let's go
one
back.
it's very close to the cellulitis I talked
There is
about.
something called erythroderma. You can read about it.
Do you know
If
the
you
one that is
look at the picture,
erythroderma though?
fungal nail infection. You can take
Oh,
some
DM, you're
of the
from
fungal
Mexico.
nail
Good to
infection.
see you. What about fungal infections?
So
You know
fungal nail
fungal
infection,
infections, they are
there's
common,
few
as
things
aren't
also
they?
for your day-to-day practice you need to know
But they
about
are
it.
quite difficult to treat.
Let's read it, but it's mainly important for clinical practice more. So it's
Mm.
called onychomycosis, and it's most commonly used by dermatophytes.
Welcome.
Sometimes it can be
Wow,
caused by
you're
yeast
Mexico.
like
How is
candida,
life
but
in
most commonly
Mexico,
is
DM?
the
Yeah, you know
dermatophytes,
fungal infection.
and
Yeah, that's
sometimes
good. So
caused
fungal
by
infection, the problem with them
non-dermatophytes
is that they can be
groups.
very hard to
Risk
treat.
include
Like if you're taking
risk
treatment,
factors
if you're
include
doing
for
treatment
fungal nail
of your
infection is
fungal nail
diabetes definitely
infection
and
or
age.
body
So both
infection,
of
you may
them
need
are
to
the
take it
most
for a
common
while
risk
before
factor
it
for
clears up.
the fungal
It's
nail
not like
infection.
antibiotics that you take antibacterials that you take antibiotics for like
Features
1 week and you are good.
unsightly nails
Fungi, you may need to
are
take it for a long
commonly a
time.
reason
In
for
fact, if it's the
presentation.
fungal
So
fit
usually the
infection,
patient will be
okay,
bothered
depending
by
on
the
the
appearance
quantity
of his
of
nail
nails,
rather than
if it's
anything
only
else.
like
So
two
usually
nails
there
or
is no
less than
pain. Usually there
50%
is no
nails, that is, thank you
nothing
for
else. Just
subscribing,
how it looks
LJ,
like. Patient will be
is
bothered by the
affected, then you
appearance
may
of
take it
the
for 3 to 6
uh,
months. Otherwise, you may
nails.
need to take it for
It
six
will
to
be
nine
it
months.
could be some thickening, roughening, opaque, opacity of the nail. This is the most
Mm.
common findings. Differential diagnosis
Thank you
could
for
be psoriasis,
subscribing,
could be
LJ.
trauma, lichen planus, yellow
Mm.
nail syndrome. This is differential diagnosis. Investigation
So,
definitely
do
is
you know do you
nail
know the one that
clipping
is
for
called
morphology,
HIV though?
nail function,
Everyone
and
should know that,
sensitivity,
isn't it?
or sometimes
We
you
all
can
know
do scraping
HIV,
of the
don't we?
affected nail and send it also
HIV
for
can give some
mycology
skin
culture and
infections.
sensitivity.
Both the one that is called
Management
seborrheic
don't need to
keratosis,
be treated
molluscum
if asymptomatic
contagiosum.
unless the patient is puzzled with the appearance. As I mentioned, doesn't cause any harm. Only if the patient is
LJ,
not
thanks
happy
for
with the appearance, you
subscribing.
can manage. So diagnosis should be confirmed before
So happy
starting
new month. How
treatment.
was your
But
day?
this is for the oral treatment. For topical, patient definitely can try topical treatment without confirming the diagnosis. So dermatophytes, it can be treated by oral terpenophen. This is the first line management.
So when you get
And
like
also you
the
can prescribe
fungal
oral
body infection, we can give you a cream that is called
intravenous, okay,
terbinafine
as alternative management
or even
from 6 weeks to
miconazole
3 months.
cream.
This is for oral therapy, okay? We are talking about the oral therapy.
Mm.
6 weeks to 3 months if it's fingernail, and 3 months to 6 months for the toenail. Candida albicans, mild disease, should be treated with topical anti for that. So for oral therapy, okay, we are talking about the oral therapy. 6 weeks to 3 months if it's fingernail, and 3 months to six
So may
months
this
for
month
that
bring you a lot of
toenail.
blessings, millions of blessings in the name of Jesus. This month you're going
Candida
to have
albicans,
lots of good
mild
news.
disease, should be treated with topical antifungal.
Can I have say?
And again, it can be managed
Okay.
with oral if severe or not responding to the
Yeah.
topical. If
Go
topical
take it
treatment, you have to know
downstairs
that
if you don't want.
duration
Do you
for
want me to
the
feed you though?
toenail is 9 months to 12 months, and for fingernail is 6 months.
Go give
For
Auntie God's
toenail,
favor to feed
it's
you,
9 to
okay?
12 months.
Give it
So
to
the
Auntie
treatment
Favor
of
to feed
first
you. Be
line is
careful so you
topical.
don't
Let's move
spill
to
it,
topical,
okay?
okay? Because oral require monitoring and require baseline investigation for for liver function, and require also confirmation of diagnosis by culture, okay? But definitely for your day-to-day practice, if you have patient, you will advise them to use over-the-counter antifungal for at least 6 months if it is in the hand, or 9 to 12 months if it is in the foot. Usually patient will not have the patience to finish the course of treatment. He will try for a couple of weeks or couple of.
So for fungal infection, you do not need to be treated if you are symptomatic and you are not bothered by the appearance. But we need to confirm the diagnosis by taking a scraping of your nail. Take it to microbiology. If it's a dermatophyte infection, we'll give you oral terbinafine, um, or with oral triconazole as alternative or miconazole. Then 6 weeks to 3 months therapy is needed for fingernails infections. White toenail should be treated 3 to 6 months, and treatment is successful in around 50 to 80% of patients. Candida, mild disease should be treated with topical antifungal like amorphine, while more severe infection should be treated with oral itraconazole. So, if topical treatment is given, treatment should be continued for 6 months for fingernails and 9 to 12. So you need to continue when you if you get a fungal infection, please can you be patient to treat it for no let it eradicate. You've got to take time. Okay. Continue the treatment for about 6 months for fingernails and 9 to 12 months for your toenails.
Response and will come say, I'm
So
not
if you get
responding,
a
I would like to
fungal
start the therapy.
infection, that's what I'm saying.
So at the
If you
time,
get a
we can
fungal infection,
discuss with the
if it's
patient
the
if you need to
fungal, if it's
confirm
your
by
hand,
taking the
finger, or your toe, you need to be
mycology
patient
culture
because you may need to
sensitivity,
take treatment
and
up to
then
six
you can
months,
start
sometimes
the
9 months. Patients
oral
are not always
terpenafine or
patient to take the
itraconazole,
treatment for a
but
long
after
time.
having baseline liver function test. Okay.
Mm. And we have to check your
As
liver
I
before
mentioned,
we
this is
give you
for
certain
day-to-day practice rather
medication.
than exam wise.
Mm.
Terpenafine oral or topical. So terpenafine topical available and oral if he is willing to be on oral. So both of them are available. Okay.
6 months for
Culture and
fingernail.
sensitivity will be quite useful to decide what or to detect what are the causative fungus. But because it's more above 90%, it should be dermatophytes. That's why terpenafine is the first line.
Mm.
So another topic is granuloma annular. How you can get us about that? Definitely picture. Okay, definitely picture. So
Do
how
you
it
know
looks
the one
like?
that is
Just you
called
need to take note of the
psoriasis,
picture and
though?
know how it looks like. This is how it looks like. Okay. So what are the other reasons that you can get confused with this one? If you know about the appearance. So this appearance similar to which appearance? This one specifically the right picture, the right this hand, not this one. This one. No, sebaceous cyst will not be like that. This one's more or less looks like molluscum contagiosum. Okay, molluscum contagiosum. So I think we have one picture here. Here, this is molluscum contagiosum. Can appear like molluscum. It's not implicated typically like molluscum, but
Okay, let's quickly
it
go
can
now.
looks like molluscum. Okay. However, if it is like that, it's a little bit different. If you will have it, it will be picture. It's not common, but
I'm not dressing
it
like
will mostly be
official.
how it looks like.
You wish is
Mm.
your own body. Anywhere you wanted to, you see, you be looked and you look fine. That concerns you.
I don't want to look fine. Thank you.
Hereditary hemorrhagic telangiectasia, you can read about it. Hidradenitis suppurativa.
Mm.
Hidradenitis suppurativa. It's important, okay? It's important to be aware of it. So let's go through it, and also I'll tell you because it's also important in the day-to-day practice. So hidradenitis suppurativa is a chronic, painful, inflammatory skin disease characterized by development of inflammatory nodules, pustule, sometimes sinus tracking, scarring in the intertracheous area. Okay, usually between thigh and genitalia. Sometimes it can appear in the armpit or the lower abdomen. Okay, between if patient has a big belly, so it appear increases in general. Okay. So it should be suspected in pubertal or post-pubertal patient who have diagnosis of recurrent truncles or boils, especially in the area we mentioned. Okay. Uh, Epidemiology: women are most likely affected than men, and it's more commonly affecting adults below 40 years old. Risk factors: definitely family history, obesity, diabetes, polycystic ovarian syndrome, smoking, and sometimes mechanical stretching of the skin. Okay. Clinical feature, initial manifestation involve recurrent, painful, inflamed nodule. Sometimes it occurs commonly in, as we mentioned, in the intertragus skin. However, non-intertragus skin involvement also can be seen. Axilla is the most common site. Other areas include inguinal area, inner thigh, perineal area, perianal area, and inflamed or inflammatory skins. Nodules may rupture, discharge purulent, malodor material. Sometimes they can collect to each other and cause something called rope-like scarring. Diagnosis clinically, management, good hygiene definitely, loose fitting clothes, smoke cessation, so you have to get rid of the risk factors. Weight loss if obese, acute flare may be treated with steroid or flucloxacillin because it will be like infection frontals or boils. Long-term disease can be treated with topical clindamycin or oral lemmicycline or clindamycin, sometimes rifampicin. Lump that persists despite prolonged medical treatment will need to be removed surgically. Complication, as we mentioned, sinus tract formations, fistula formation, comedones, scarring, and sometimes contracture or lymphatic obstruction. Differential diagnosis, acne, follicular pyodermas, and granuloma inguinal. Just I mentioned that because you can see that frequently in young patients attending with frequent infection or infected, sometimes you will diagnose him as infected sebaceous cyst or fruncles or boils, but take the patient file if he's attending frequent for the same problem, think about hidradenitis suppurativa, okay? Hirsutism and hypertrichosis. Uh, Causes is important. So this condition, the important thing about that is the causes, okay? Specifically medication. So specifically the medication. So hirsutism is often used to describe androgen-dependent hair growth in women with hypertrichosis being used for androgen-independent hair growth. So both of them excessive hair growth, but one of them is androgen-dependent and another one is not androgen-dependent. Polycystic ovarian syndrome is the most common cause of hirsutism. However, other causes is Cushing syndrome, congenital adrenal hyperplasia, androgen therapy, obesity, adrenal tumor, androgen secreting ovarian tumor, and phenytoin and corticosteroid. Okay, so this is the causes of hirsutism. Management of hirsutism. So definitely it depends on the cause. So advice about weight loss, cosmetic techniques sometimes can be used. Consider using combined oral contraceptive pills with polycystic ovarian syndrome, facial hirsutism, topical eflornithine. This is important. Sometimes you can get asked about that. Contraindicated in pregnancy and breastfeeding. What are the causes of hypertrichosis? So again, drugs is important. That very often used to describe androgen-dependent hair growth in women with hypertrichosis being used for androgen-independent hair growth. So both of them excessive hair growth, but one of them is androgen-dependent and another one is not androgen-dependent. Polycystic ovarian syndrome is the most common cause of hirsutism. However, other causes is Cushing syndrome, congenital adrenal hyperplasia, androgen therapy, obesity, adrenal tumor, androgen secreting ovarian tumor, and phenytoin and corticosteroid. Okay, so this is the causes of hirsutism. Management of hirsutism. So definitely it depends on the cause. So advice about weight loss, cosmetic techniques sometimes can be used. Consider using combined oral contraceptive pills in females with polycystic ovarian syndrome, facial hirsutism, topical eflornithine. This is important. Sometimes you can get asked about that. Contraindicated in pregnancy and breastfeeding. What are the causes of hypertrichosis? So again, drugs is important. Minoxidil, cyclosporin. As you remember, minoxidil we use it for alopecia or hair loss, so it can cause excessive hair loss. Okay, so it can cause excessive hair loss. Excessive hair growth. So minoxidil, we described that, mentioned that about the management of alopecia. So it can cause excessive hair growth. Okay, minoxidil, cyclosporin, and diazoxide. This is for hypertrichosis. For hirsutism, it's phenytoin and corticosteroid. Congenital hypertrichosis can be one of the causes. Congenital, porphyria cutanea tarda, one of the causes. Anorexia nervosa, one of the causes. Okay, so this is for the excessive hair growth, either hirsutism, which is androgen dependent, or if it's not androgen dependent, this is the causes. Okay, you can ask about that straightforward question: which is the following cause of the, and then mention hirsutism or hypertrichosis, or which is the following medication can lead to hypertrichosis, and then you have to pick up the right answer. Okay, hyperhidrosis, excessive sweating. Management of excessive sweating. So what you need to know is that botulinum toxin, one of the options. And when we talk about the when we talk about neurology, we will take the botulinum toxin in indication or uses. One of them will be hyperhidrosis. Okay, hyperhidrosis, but definitely in axilla. Axillary hyperhidrosis, not anywhere else. Only the axillary hyperhidrosis. Topical aluminum chloride preparation is the first line. Ionophoresis, one of the options. Botulinum toxin for axillary hyperhidrosis, and sometimes surgery. Clinically, I saw some patients managed under the endocrine, and they give them oxybutynin for the hyperhidrosis, and it was quite useful. This is one of the things I saw that specialists doing. But it's not for here anyway, and you will not go for that by your own. It should come from the specialist anyway. Impetigo, very, very important. Impetigo, very, very important. There is a couple of things that you need to know about impetigo. Okay, this is one of the things I saw that specialists doing. But it's not for here anyway, and you will not go for that by your own. It should come from the specialist anyway. Impetigo, very, very important. Impetigo, very, very important. There is a couple of things that you need to know about impetigo. Okay, first of all, positive organism. Second of all, school exclusion. Third, management. Okay, and definitely how to pick it up clinically. So impetigo is superficial bacterial infection caused by Staph aureus. So the organism most commonly Staph aureus or Streptococcus pyogenes. Okay, it can be primary infection or complication of an existing skin condition, such as eczema or scabies or any skin condition cause itchiness. Infection can develop anywhere in the body. However, it's more common to the face and flexor cervicis, and sometimes on the limb also. Spread by direct contact with discharge coming out of the scapes of the infected person. Features: the characteristic feature is the golden crusted skin lesion. This is the characteristic of the impetigo. So the characteristic feature is the golden crusted skin lesion. So this is the characteristic feature of the impetigo. Management, it depends on the severity. So if it is limited, localized, NICE guideline advice for topical hydrogen peroxide 1%. For people who are not systemically unwell or at risk of complication, this change was announced later. So the first thing is topical stuff. So topical hydrogen peroxide. And then you can prescribe topical
Hey, I'm
antibiotic
from
if required.
Nigeria.
Salicylic acid is the first thing.
Neng, pleased to meet you. How are
one of the
you?
things that you can prescribe
I'm
if
from
salicylic
Nigeria,
acid
but I live in
resistant,
the UK.
or if there is
Happy New
MRSA
Month to
suspected.
you.
Okay? Because
How are you?
so
How
the
was your day?
Urocin used mainly for the MRSA decolonization. So if you suspect MRSA, multi-drug resistant Staph aureus, you have to go for the second option, not salicylic acid. If it is extensive or severe, go for oral and you will treat like cellulitis, flucloxacillin, or erythromycin. Very important, school exclusion, very important. Child should be excluded from the school until 24 hours after starting
Oh,
the
you're from
antibiotic
Indonesia.
or
Nice
until
to meet
all
you,
lesions
lovely.
are
How is
crusted. Okay?
Indonesia?
So
What's
this
the
is the
time in
important
Indonesia at the
points that you need to know.
moment?
Management, full exclusion,
Mm,
positive organism, or
nice
diagnosis.
to meet you,
Okay, how it looks
lovely.
like. This is a couple of pictures, and here also we have a couple of 48 hours after starting the antibiotic, or until the all lesions are crusted. There is two advice for the full exclusion. Either wait for until dryness and crusting of all lesions, or after 48 hours starting the antibiotic. Okay, so this is how it looks like. As I mentioned, the golden crusted lesion is the most characteristic feature that will help you to diagnose the condition. Okay, so picture what are the diagnoses, picture what are the causative organisms, picture what are the management. Okay, picture for how long this child should be excluded from the school. Okay, uh, juvenile
Oh, bless
spring
you.
eruption, you can read about it.
It's
Keloid, you can read
okay.
about it. Keratoacanthoma, very important. Keratoacanthoma, very important. The kerato spring eruption, you can for how long this child should be excluded from the school. Okay? Uh,
So, we have to. At least you go do the way you told me somebody knock because I'm in the kitchen. So what put us there? What about go inside already? Made them make proposal. Maybe on no door opening. But I was the one who tell my say yes. China's a nose there. Who is it? They say we are leaving tomorrow. Say yes. So okay, all the best. You lock.
Okay.
Say how about the land is it good? I say well we are just managing. And everything is not too bad. Say people that live here before, they complained that I didn't treat them well, and that was why they packed out.
It wasn't too bad to us, to be fair.
Well, too bad, but the man not in nature by nature. I don't know why easy going person. So,
It wasn't too bad to us. Oh, deposit, Kaiga, my again, but it wasn't too bad, to be fair. Okay.
juvenile spring eruption, you can read about it. Keloid, you can read about it. Keratoacanthoma, very important. Keratoacanthoma, very important. The keratoacanthoma is very important. So let's go through it and then we'll mention how you can get asked about that. It's a benign epithelial tumor, more common with advancing age. Feature is
Welcome and study with me, okay? I'm studying.
appearance, initially smooth shape, papule, rapidly grow to become carter, centrally filled with keratin. Okay. Spontaneous regression of keratocarcinoma within 3 months is common, often resulting in scar. Such lesion should, however, be urgently incised, as it's difficult clinically to exclude from squamous cell carcinoma. Definitely, removal should be done to prevent scarring. So this is how it looks like. Then we have a couple of pictures here.
bet something.
Those shape, central, keratinized.
Mom, there's two people at the door.
That's what to say you bought. Bed cover. You need to get us so I will get them ready so that we put them in the morning before we start going.
It's in the boot of the car. So if this is my car key, will lay under the boot. And I'm not when we came to we put in a palo, I'm which in the back there.
You carried it.
I don't know, just check the boot of the car. Be careful, there's a breakable plate there. So up on anything with force.
Center, loop shape or volcano shape. Okay. So this is how it looks like. How you can get us about that? Simply picture and what is the diagnosis. Picture what is the diagnosis. Okay. picture, what is the management to be referred, because it looks like the squamous cell carcinoma and you need to confirm diagnosis, okay? And it will need to be removed anyway. But usually you get asked about diagnosis. So we'll ask you what is the diagnosis, okay? Next question, next topic is ketoconazole. You can read about it. Kopner phenomena, you can read about it. You need to know which condition associated with Kopner phenomena. So Kopner phenomena is the lesions that appear at the site of injury, and it's seen in the following conditions. Lentigo maligna, you can read about it. Leukoplakia, we talked about that already in ENT, and we saw picture for that in ENT. So if you review the ENT, you should remember what we mentioned about that. Usually we'll have picture, tongue, and lesion below tongue, and then ask you about the diagnosis or the management. So it's important. Leukoplakia very important, but you can write for yourself. It's covered under the ENT. Lichen planus is a skin disorder of unknown etiology, most probably being immune mediated. So lichen planus, how you can get asked about that? Most probably picture and diagnosis or picture and management. Okay. So lichen planus is a skin disorder of unknown etiology. Features is itchy papule or papular rash, most commonly on the bulb, sole, genitalia, and flexor surface of the arm. Rash often polygonal in shape with white line pattern on the surface. Kopner phenomena can appear or can be seen, so new lesion appear at the site of trauma. Oral involvement can happen in 50% of the patient. So what are the, lichenoid drug eruption, or what are the medications that can lead to this eruption? Gold, quinine, and thiazide. Management is potent steroid. This is the main management. Benzidamide can be used mouthwash if you have
Thank you, DM. Stay focused, my lovely.
So
yeah.
mainly
Amen. Amen. And may your dreams come true. DM, you are so kind.
We have a couple of pictures
You're so
here.
kind. Thanks for your kind words.
Like.
Okay. I'm
That's
reading
the
what is called
characteristic
lichen
white lines
planus. Have you heard
appearing here.
about it
Don't
before?
get confused between
It's a
lichen
skin
planus
problem.
and
Have you heard
where is
about it? It will come in with pink, purple, something
just show you,
issue
yeah.
in the
And
skin.
chronic plaque
That's what
psoriasis,
I'm
okay?
reading for my
Please don't get
forthcoming
confused between these
exam.
two pictures.
Have you
okay?
heard of psoriasis? I'm also
So
reading
this
about
one is chronic plaque
psoriasis.
psoriasis, well demarcated borders, patches, and looks like there's some scaly white, sometimes scales on top of the lesion. Here it is more or less different, small, rounded, and then you can have the white patch on top of it, some round, small. Lichen planus is different from the other one. If you can see it over the mucosa of the mouth, it will be like, as you can see, white patch or white mesh-like or reticular shape, white lesions in the mouth. Okay, lichen planus could be on the mucous membrane, could be on the extensor surface, or on the bulb or the upper hand or extremities. Okay. So how we can get asked about lichen planus? Most probably picture diagnosis, or picture and management. Strong, potent, or potent steroid. Okay. Lichen sclerosis, another condition. Just also we read about it. It's not as important as the previous one, but let's go through it. So it's previously termed as lichen sclerosis, whatever this is the name. It's an inflammatory condition, usually affect genitalia, more common in elderly female. Lichen sclerosis leads to atrophy of epidermis and white plaques forming. Very common in old ladies with vulval irritation. Okay, so lichen sclerosis most commonly seen in old ladies with vulval irritation. Feature white patch that may scar. Its itch is prominent, or patient complain of itchiness, may result in pain during intercourse or urination. Diagnosis usually made clinically. However, biopsy important to rule out the cancer. Okay. Management is topical steroid and immunin, and definitely patient require follow-up to make sure that he is improving on the treatment, and if he's not improving, he may need to be referred for biopsy and confirmation of diagnosis. Melasma, the only way that you can get asked about that is picture and ask you about diagnosis. Is important also to be aware of. Causes is pregnancy, combined oral defense, and hormonal replacement therapy. Okay. So melasma is important, diagnosis, picture, diagnosis, and what are the associated condition or causes, and this is how it looks. So this is lichen sclerosis, how it looks like. It can appear anywhere, but commonly in the genital area. This is the melasma, okay? This is the melasma. So very important to know how to take it out clinically. Usually, Dr. Nermin, topical steroid in general not to be used for long term unless in certain conditions like psoriasis and some other conditions. So usually you will try it for a couple of weeks and then check if patient is not responding, you will refer. This is usually what we do in the primary care. If patient is not responding to the topical steroid within a couple of weeks, you should stop and then send the patient unless he has conditions that require longer duration of treatment. Okay. So melasma, definitely what you can get, how you can get asked about that diagnosis. Okay, picture and what is the diagnosis. Okay. Uh, okay. So next topic is molluscum contagiosum. Just you need to read about it, know the positive organism. I put for you a couple of pictures, know how it looks like. Molluscum contagiosum. Okay.
Kaima.
And the most important thing that you should know that it may take up to 1 year to resolve. Okay. So sometimes a few months. So let's just go quickly. It's molluscum contagiosum is happened by the molluscum contagiosum virus, and this is a cause, it's viral infection. It's a member of the Cocci-Varida family, transmission directly by close contact or sometimes indirectly. Typically present with characteristic pinkish pearly white papule with central amplification, which are up to 5 millimeter diameter. Lesion appear to encrust, so appear few lesions together and can appear at any part of the body. So self-care advice, reassurance, it's self-limited condition. Spontaneous resolution can happen after 18 months. This is one of the things that you should be aware of. If you have any mother with child and you are suspected of causing molluscum contagiosum, let them know there is no specific treatment. Let them know that there is no specific treatment. It can last for 1.5 years. Okay, so this is one of the things that you should share with the mother. Okay. Important to explain that the lesions are contagious. Lesions are so you can imagine 18 months being contagious is not something easy. That's why explanation is very important. Let the mother know about the condition is very important. Encourage patient not to scratch the lesion. Exclusion from school, gym, swimming is not necessary. So this is regarding that. Mycosis, fungoids, you can read about it. Nickel dermatitis, you can read about it. Onychomycosis, you can read about that. Pellagra, just you need to know that this is due to deficiency of nicotinic acid. You can read about it. Pemphigus vulgaris. It's important to know how to diagnose that clinically by the picture. Okay, so how you can get asked about that picture and then ask you about the diagnosis. And he can ask you about the management to be steroid, definitely. Sometimes patient require immunosuppression, but definitely pemphigus vulgaris, you will have it in the form of scenario, picture, and ask you about the diagnosis. We saw it already. We have a couple of pictures earlier. Very orificial dermatitis, you can read about it. Conflicts just because you can have it in the form of picture, so you need to know about it. So I have a couple of pictures here. This is how it looks like. So let's go through it quickly. Conflex is a type of eczema which affect both hands, okay, and feet. It's also known as dishing eczema. So conflex is just type of eczema and mainly affect hand and feet. That's what you need to know. It may be precipitated by humidity, high temperature. Small blisters will appear in the palm and sole, and it will be pruritic. Pruritic means itchiness. It's often intensely itch. Sometimes patients have burning sensation. How to manage topical steroid, definitely, and also it will help to apply some cold compress and emollient, but it will be managed same as the eczema. candidiasis versicolor, how you can get asked about that? Mainly picture, diagnosis, picture, management. Okay, so it's viral, it's fungal infection. It's fungal infection by Malassezia furfur, and commonly affect the trunk. It can appear in patchy growth, pink or brown area, maybe also appear like suntan. Sometimes patient can have scales. Sometimes it can be mildly itchy. It's not that much itchy like other conditions. Predisposition is humidity, can happen in healthy individuals. Malnutrition can predispose to the condition. Caution predispose. Immunosuppression can predispose. However, it can happen in normal individual. Because it's fungal infection, treatment is topical antifungal. Patch on the skin, although it's now recognized that patients with psoriasis are at increased risk of arthritis and cardiovascular disease. This is very important. This statement very important. Why? Because you can have question about patient with psoriasis, which of the following should be done. So you will have one of the options is calculation of cardiovascular risk, use Q risk score. Okay, this is very important. So patients with psoriasis will be at risk of arthritis and cardiovascular disease. It's important to calculate cardiovascular risk in patients with psoriasis. Don't forget about that. Subtypes you can go through that: the plaque psoriasis, flexural psoriasis, the plaque psoriasis, and pustular psoriasis. Psoriasis can affect fingernails, can affect also joints, as we mentioned. Complication is important. Psoriatic arthropathy, we talked about that already on the muscle-related chapter. Increased incidence of metabolic syndrome, increased incidence of cardiovascular disease, increased incidence of venous thromboembolism, and psychological distress. Definitely one of the complications. Here another pictures. We have picture earlier, and this is another pictures. And here are the features appearing in the nail. You can read about it. What are exacerbating factors? Very important. You can ask about that straightforward. So let's go again. Psoriasis picture, diagnosis. Psoriasis associated with cardiovascular risk and arthritis, associated with this complication, but cardiovascular is very important. Any patient with psoriasis should have cardiovascular risk assessment. Don't forget about that. Write that for yourself. And exacerbating factor is important. So what are the exacerbating factors? You can get asked about that either what are the factors, or it will be straightforward question, or sometimes they ask directly about the medicine, which is following medication. The pictures, we have picture earlier, and this is another pictures. And here are the features appearing in the nail. You can read about it. What are exacerbating factors? Very important. You can get asked about that straightforward. So let's go again. Psoriasis picture, diagnosis. Psoriasis associated with cardiovascular risk and arthritis, associated with this complication, but cardiovascular is very important. Any patient with psoriasis should have cardiovascular risk assessment. Don't forget about that. Write that for yourself. And exacerbating factor is important. So what are the exacerbating factors? You can get asked about that either what are the factors, or it will be straightforward question, or sometimes they ask directly about the medicine, which is following medication can clear up the psoriasis. I had one patient who had psoriasis and was started to get worse and worse, frequent flare up. And then we have to. I had one patient who had psoriasis and was started on beta blocker by a cardiologist, and his condition started to get worse and worse, frequent flare up. And then we have to switch, discuss with cardiology about alternative for beta blocker for him. So trauma, alcohol, beta blocker, lithium, anti-malaria like chloroquine, hydroxychloroquine, non-steroidal anti-inflammatory, ACE inhibitor, influence map, all of these are triggering factor or exacerbating factor of psoriasis. Very, very important. Sometimes withdrawal of systemic steroid can flare up psoriasis. Okay, so exacerbating factor is very important. management. So management is very important. So let's talk about the most common one, the chronic plaque psoriasis. Nice recommend stepwise approach for chronic plaque psoriasis. So regular emollient definitely you have to apply. First line management is potent corticosteroid. Potent, as I mentioned, you have to know what are the examples of potent topical steroid. Okay, question may ask you about the which of the following preparation to pick up. So potent corticosteroid usually applied once daily, plus vitamin D analog applied once daily. Usually there will be some in some surgeries you can have some local guidance, which is a little bit slightly. It will not be a big difference, but sometimes about the duration of treatment, when to refer, it will be different from place to place. So you have to review your local guidelines or guidance if you have. So first line management is potent topical steroid once daily along with vitamin D analog once daily. Should be applied separately, not at the same time, one in the morning, one in the evening. Can be used for up to 4 weeks as initial treatment. So here, Dr. Hussein, for this one, as I mentioned, psoriasis will be for long period, not only a couple of weeks or 1 week, and assessment will be at 4 weeks. Second line, if no improvement after 8 weeks, then you have to go for the following option. You will offer vitamin D analog twice daily instead of once daily. Third line management with no improvement after 8 to 12 weeks. And then you will put potent steroid applied twice daily instead of once for 4 weeks, or cold hard preparation applied once or twice daily. Short acting dipranol can be used. So the management, potent steroid once daily along with vitamin D analog. If not helping, you will increase the vitamin D analog to twice daily. If not helping, you will increase the corticosteroid to twice daily. Okay. Secondary care management, what they are doing is phototherapy for resistant case. Systemic therapy, sometimes they will give immunosuppressant like oral methotrexate is the first line for resistant cases, and it will be only applied. By the secondary care. Another immunomodulator can be used like cyclosporin, systemic retinoid, biological agent like infliximab. All of this can be used by the secondary care. Okay, so do not get confused. Psoriasis, picture and diagnosis, psoriasis, associated complications, psoriasis with exacerbating factor, psoriasis management. Okay, management, what you need to be aware of is primary care management. So potent steroid and vitamin D analog, okay? Once daily, and then for the stepwise approach, you change the second line and third line. Secondary care, just know the names. You need to know about the names or the headlines on secondary care management. So phototherapy, systemic therapy with immunosuppressant therapy, oral methotrexate is the first line, cyclosporin or another options are available, okay? Another, some difference is depending on the site of the psoriasis. So scalp psoriasis, nice recommend use of potent steroid, corticosteroid once daily for 4 weeks. If no improvement after 4 weeks, then either use different formulation of the potent steroid, so change the preparation, but still give strong or potent steroid. But instead, like if you are using cream, use shampoo. If you are using shampoo, use Mose, or yeah. So just preparation, you will change the preparation you are using, or topical agent to remove adherent scale like the emollient we mentioned earlier, or salicylic acid. Face or flexural or genital psoriasis, nice recommend to use moderate to mild potency steroid. So here in the face, you will not apply the potent. Usually, you don't put potent on the face. Moderate or mild potency steroid for the face, genital area or flexural area, because skin will be more fragile and weak at this area. And usually it will be applied once or twice weekly for 2 weeks, not 4 weeks like the previous one. Notes on medication, you can read about that because to give you information about the vitamin D analog, side effect, information about how it works, information about the topical steroid, we already covered that. Just you can read about that. Referral criteria, it's important also, but as I mentioned, it can be different from area to area, so you have to make sure that you are aware of your local guidance. You can stop after improvement. There is no advice about gradual weaning off for topical steroid. Usually weaning off will be for oral one. If you're giving oral for a long time, you have to wean off. But for topical, no. I didn't experience that before. Referral criteria, although 60% of the patient will require referral to secondary care, NICE provides some pointers to in their guidance given the chronic nature of the psoriasis. So when you refer, definitely if you are not sure about diagnosis, you refer, first of all. If you're so actually this one in all dermatology condition, if you are not sure about the diagnosis, if you have any suspicions about the diagnosis, you can refer the patient. If any type of psoriasis is severe or extensive, for example, affecting more than 10% of the body, if any types of psoriasis cannot be controlled with topical therapy or acute goutte psoriasis, definitely require a referral. Children and young people with any types of psoriasis should be referred to specialists at presentation. This is one of the things, we have also in our local guidance. If you have child with psoriasis and this first presentation, refer for confirmation of diagnosis, and then you can follow up the management later. Systemic complication, again, we repeat, very important. So psoriasis has increased risk of cardiovascular disease, hypertension, venous thromboembolism, depression, ulcerative colitis, Crohn's disease, non-melanoma skin cancer, other cancer, including liver, lung, upper gastrointestinal tract cancer. Very important, okay? So systemic complication, very important. You can ask about that directly or indirectly. Directly by asking direct question, indirectly asking about what should be done for this complication or to screen for this complication. Again, systemic therapy and biological treatment, you can read about that. We already covered side effect of this medication in the rheumatology chapter. So definitely side effect of methotrexate is very important. Side effect of biological agents is very important. Okay, so we can stop here and we can continue next time. We already finished almost more than half. We can finish next session the rest of the dermatology. As I mentioned, it's a little bit silly chapter, heavy chapter, and I think it would be a good idea to have the rest in another session. So I think I'll be available on next Friday at the same time, if it is okay with you. So next Friday around 8 p.m. Next time it should not be long. I think it will be around 1.5 hours maybe. We almost finished most of the topics. The only important thing left is maybe the melanoma, squamous cell carcinoma, some other couple of important topics we are going to cover. So let's have another session for dermatology next Friday at 8 p.m. We'll finish the dermatology. I'm going to upload today the files appearing on the screen. So you should have it before the next session. Make sure that if you have time, you go through it. If not, you can wait for the next session and then study that over the weekend. Okay? Does anyone has any question for me for today? Yeah, definitely, Mr. Mohammed, yeah. Looks like that you are attending for the first time. So yeah, anything we are having on the screen will be uploaded. Any session we are having will be recorded and uploaded to the drive. So if you have the drive, okay, Dr. Farhan, I will put the antibiotic under the file folder in the drive. Okay, so in the drive you'll find some folder named files. I will put the antibiotic one under files. Okay, because general one, and then we'll upload that later for the infectious disease.
Dr. D, Alpha.
Now. I sent you message since 7 o'clock. I didn't know that you have already started already.
I've already entered the meeting waiting for you. So I don't wait. I'm like, okay, let me come on. So I didn't see your message if you had messaged me, to be fair.
Okay, I did not know that you have.
No wahala. How far now? How you there?
Why no?
Hope you managed to rest a little bit.
Yeah.
Because this is our marathon reading we are doing, but we need it though. Like we need it. Like yeah, because we need to ginger, because you with your small baby, I don't want you to do through this again. May God help us. Let's just do it once and waka. You do it once, make we just waka, no say it don't pass. All right, but I know it's doable. Shebi people they pass them, so we'll pass. My dear, somebody was telling me that if there are difficult, if exam is difficult, but was it really difficult and people and cutoff was that high? I don't want to believe that the exam was difficult. I want to believe that is the preparation, because Happiness said that her own said that she failed. The cutoff was even lower. So
that
yes,
means people pass more.
That means people passed more in this one. Yeah, that's what Happy said. Okay, so we're doing the math, isn't it? Can you see my screen?
Yeah. What was Happy's score? Did she tell you?
No, she didn't tell me her score, but she said she told me she luckily escaped.
So it wasn't that easy like that.
Like dear God will help us. We'll be all right. So you are reviewing an 82-year-old. Her target is 100 questions. So let's see. So 82-year-old woman that's developed sore on her leg. For the past year, she had dry, itchy skin around her ankle, but over the past few weeks, the skin has started breaking down. And this is the picture. What's diagnosis? Necrobiosis, lipoidica, diabeticorum, pyedoma, gangrenosum, arterial ulcer, venous ulcer, tibial mesoderma. This is pyedema, isn't it?
Yeah. So it's not diabetic, abi?
Venous, what? This is not looking venous. This is looking pyedema. Develop sore.
On the media surface.
As in they said develop sores on her leg. For the past few years, she's had dry, itchy skin around her ankle. But over the past few weeks, the skin has started to break. This is pyedema now. Let's see what they say. The dry skin represents varicocele. Okay, is it because of the previous dry skin? She's had, maybe because the dry, itchy skin now, man. So dry skin, I was almost going to swear that this is pyedema. Yeah. So the dry skin represents varicocele. Material also tend to have a more punched out appearance. Oh. So let's see. Oh, they didn't even give us any picture. Venous ulceration. So what did they say it is? They say is so this guy has some pictures. That means I have to go and consult those pictures in that material. Let me open it. This guy has some pictures in dermatology, so let me go and explore it, because I can't believe that is not
Omar's picture.
Omar has a picture for dermatology, so let's go to the pictures. He just labeled it.
Okay, I think I've seen the pictures. It's like that stuff we're using to read for statistics, abi?
Something like that. Yeah, I think he's even in the group. So what did they say is the diagnosis again? Let me look for it.
Venous ulcer.
Venous ulcer. I want to see if there are venous ulcer, because that thing look like pyedema, pure pyedema. That's what it looks like. So I'm just these people should just stop confusing somebody. Okay. So erythema abigine, erythema multiforme, nodosum, erythema migrans, erythrasma, erythrocyte. Can't even believe that is not. Lichen sclerosis. If you go for that exam, the way you be seeing pictures like this, the kind of pictures these people bring out, you be wondering if the picture is from the pit of hell or from heaven, where they are coming from. Necrobiotica.
When I thought dermatology questions, like maybe 2 or 3.
Well, it depends, There's just the way the thing used to be. They don't have like the thing don't finish. I didn't see any picture, any of that. I want to see. Let's continue, but that thing looks like pyedema. I don't know why that's. I'm not happy with that stuff. What they said there, it looks like pyedema. So, can you check PCDS? Let's see, because I'm not that.
Venous ulcer is not even this many. Let me check.
Exactly. Pyoderma gangrenosus. Although it shall look PCDS. It shall look
Huh?
it shall looks neat. That's the only thing I know. Pyoderma used to look quite ugly. But even at that, it's still
The only reason why I would say it's likely venous ulcer is because of the history.
The history, share.
Yeah, that's the only why. Not because it's dry skin.
The history, yeah, the history.
Eczema.
The history. Okay. So venous ulceration is typically seen above the medial malleolus, even though this is not the medial malleolus, which is the same thing with what you were saying. Investigation, do ABPI is important in non-healing ulcer. Okay. If normal ABPI between 0.9 to 1.2, then value below 0.9 indicate arterial disease. Thank you. Management is compression bandaging, usually 4 layers. That is the only treatment shown to be have real benefit, but we can use pentoxifylline and small evidence support of flavonoid. Little evidence to suggest benefit from hydrocolloid dressing, topical growth factor, ultrasound therapy, and intermittent pneumatic stockings. Okay. So the next one is 54-year-old woman prescribed topical fusidic acid for small patch of impetigo around her nose. She's recently been discharged from hospital following varicose vein surgery. 7 days after starting treatment, there has been no change in her symptoms. Examination revealed persistent small crusted area around the right nostril. While awaiting the result of swab, what's most appropriate management? Oral vancomycin, oral erythro, topical metro, topical bupirosin, fluclos. So if it's not responding to, we do hydrogen peroxide. They're not responding to hydrogen peroxide. We do fusidic acid. They're not responding to fusidic acid. That the next thing is bupirosin, isn't it?
I guess so. At what point do we use fluclos then?
You use fluclos when there's now systemic infection or they start having fever or something. So MSRA should be considered given the recent hospital stay and lack of response to fusidic acid. So topical bupirosin is therefore the most appropriate. So now recommend hydrogen peroxide 1% cream for people that are not systemically unwell or at risk of complications. Change was announced in 2020. The evidence base shows that it's just as effective as treating non-bullous impetigo. Local antibiotics cream, topical fusidic, bupirosin should be used if fusidic resistant. Yeah, an extensive disease is where you use oral fluclos, oral erythro if fluclos allergic. School exclusion until the lesion are crusted or 48 hours after commencing antibiotics. 3-year-old boy is brought to the general practice by the mother, reporting a sudden onset of rash in the arm, chest, and around the mouth. On examination, you observe multiple monomorphic papulovesicular lesions with punched out erosions, each approximately 1 to 2 mm in diameter, accompanied by crusting over the lesions. The child has a history of eczema and recently commenced nursery school. What's likely diagnosis? So 3-year-old boy brought to practice reports sudden onset of rash on the arm, chest, and the mouth. You observe multiple monomorphic papulovesicular lesions with punched out erosions that each approximately 1 to 2 diameter, accompanied by crusting over the lesion. What's diagnosis? Eczema hepaticum, erythema multiforme, impetigo, staph scalded, varicella.
Are you sure it's impetigo? Impetigo does not affect arm and chest though.
Abi?
I was thinking
it's the hepaticum. Yeah, it's hepaticum.
Because of the history of eczema.
Yeah, so sudden onset of rash in the arm, chest, and mouth. On examination, you observe multiple monomorphic papulovesicular lesion with punched out erosions. Yeah, and the crusting was just to confuse us, Abi. So eczema hepaticum rash can be described as monomorphic punched out erosions. Circular, so eczema hepaticum is a monomorphic punched out erosion. Circular depressed ulcerated lesion, usually 1 to 3 millimeters in diameter. So, and this is a picture of one of the examples of eczema hepaticum. It's potentially life-threatening and should be admitted for IV acyclovir. A 84-year-old woman with a history of ischemic disease is reviewed in a nursing home. She's developed 10 blistering lesions in her leg. Each lesion is 1 to 3 cm in diameter. She reported that they are slightly pruritic. Examination of her mouth and vulva is unremarkable. What's diagnosis? Pemphigus, drug reaction to aspirin, epidermolysis bullosa, scabies, bullous pemphigoid. This looks like bullous pemphigoid, isn't it? He's got history of ischemic heart disease, developed tense blistering lesion in the leg. Each lesion is around 1 to 3 centimeters. It should be bullous, yeah. So blisters and bullae, no mucosa involvement is bullous pemphigoid, but if there's mucosa involvement, pemphigoid, cement is usually steroid, and these are some of the pictures. Skin biopsy, immunofluorescence will show IgG and C3 at dermatoepidermal junction. Management, refer to dermatologist for biopsy and confirmation of diagnosis. Then oral corticosteroid and mainstay. Topical immunosuppressant and antibiotics are also used in the
I can't bring it. Can't bring what you want. Continue.
Okay,
sorry.
you see a 37-year-old lady that suffered from psoriasis for her annual medication review. Which of the following associated conditions does NICE recommend she should be screened for? Psoriatic arthropathy, gout, squamous cell carcinoma, celiac disease, type 2 diabetes. Psoriatic, we screen them for cardiovascular issues as well as
I think is it type 2 or celiac?
Celiac, I think it should be celiac. Type 2 is not type 2, it should be celiac. Cardiovascular problems, celiac, what other thing do we see?
Annual medical review.
Psoriatic arthropathy. Yeah, that celiac too wasn't looking very rhyming. It's fine. Even many people went for type 2 diabetes, but I know inside me, it wasn't type 2. Yeah, I wasn't just sure.
11% went for celiac.
So all of the above conditions are associated with psoriasis. NICE recommend that patients with psoriasis should be screened annually for psoriatic arthropathy using a validated screening tool such as psoriasis epidemiological screening tool. Patients should also have their cardiovascular risk assessed every 5 years. Yeah, so that it was the cardiovascular risk I was remembering. So they should have their nails screened for psoriatic arthropathy using psoriasis epidemiological screening to the PES. So complication, it's sometimes tempting to jump straight to topical treatment when managing a patient with psoriasis, as we are keen to give them something which may potentially help. We should, however, remember that psoriasis has a number of physical and psychological complications, not just psoriatic arthritis. Patients with psoriasis are at risk of cardiovascular disease, hypertension, venous thromboembolism, depression. Yeah, so I know about depression, cardiovascular, hypertension, VTE, then ulcerative colitis and Crohn's. So is IBD, not celiac. Yeah, Crohn's and ulcerative colitis, non-melanoma skin cancer, and other cancers including liver, lung, upper GI tract. Which of the following is least associated with acanthosis nigricans? Acanthosis, gastric adenoma, Cushing's disease, polycystic ovarian syndrome, anorexia nervosa, acromegaly. Which of the following is least associated with acanthosis nigricans? Gastric adenoma, Cushing's disease, polycystic ovarian, anorexia nervosa, and acromegaly. I know PCOS will be there. Is anorexia associated with acanthosis? I don't think so. Yeah, so anorexia is correct. So acanthosis nigricans can be associated with gastric adenoma, Cushing's, PCOS, and acromegaly. Correct answer is anorexia nervosa. Acanthosis nigricans is a dermatological condition characterized by hyperpigmentation and velvety thickening of the skin, most commonly in the axilla, neck, and groin. Is often associated with conditions that result in insulin resistance, as high levels of insulin can stimulate skin cells, keratinocytes, and fibroblasts to proliferate. So acanthosis nigricans describes symmetrical brown velvety plaque that are often found on the neck, axilla, and groin. What are the causes? Type 2 diabetes, gastric cancer, obesity, PCOS. So the causes: type 2 diabetes, gastric cancer, obesity, PCOS. Acromegaly is there, Cushing's is there, hypothyroidism is there, familial, Prader-Willi is there, drug like COCP and nicotinic acid. So gastric cancer is there, Cushing is there, PCOS, acromegaly. Nah, man, all these things are just so much. God will help us. They are just too much. All right. So those are the things, but there's nothing like anorexia there. Pathophysiology: insulin resistance leads to hyperinsulinemia, which leads to stimulation of the keratinocyte and dermal fibroblast proliferation via interaction with insulin-like growth factor receptor 1. You see a 37-year-old lady that suffered from chronic plaque psoriasis of the trunk for her annual medication review. Her repeat prescription include emollient, a topical Kota prep, and a potent topical steroid cream for use when her condition flares up. What advice should you give her about self-management of her psoriasis with potent steroid? So 37-year-old lady that suffer from chronic plaque psoriasis of the trunk for her annual medication review. The repeat prescription include emollient, a topical Kota prep, and a potent topical steroid cream for use when that condition flares up. What advice should you give about self-management of her psoriasis with potent steroid? Should not be used concomitantly on same side for longer than 2 weeks. Aim for 4 weeks break. Don't use continuously on the same side for longer than 1 week. Aim for 4 weeks. Don't use continuously on the same side for more than 4 weeks. Aim for 8-week break. Don't use continuously on the same side for longer than 8 weeks. Aim for at least 4-week break. Should not be used continuously on the same side for more than 8 weeks. Aim for 8-week break. I think it's deeper.
Which one? That 8 weeks is not long.
So what is this? What is the chronic plaque psoriasis, isn't it? So yeah. I thought chronic plaque psoriasis they can use it up to 8 weeks before the 4 weeks break for chronic plaque. Then right. Then for maybe I'm talking rubbish. Yeah. No, you yes. So it's the chronic. Right, it's the chronic plaque. That's why. So I understand what you are saying, but there is the thinner part of the body. When is the thinner part of the body used for only 4 weeks? So NICE advises that potent topical steroid for psoriasis should not be used continuously on the same side for longer than 8 weeks, and that patients should aim for at least 4-week break in between courses. So very important, topical steroid should not be used continuously for more than 4 weeks. Okay, so this is the potent, yeah. So she's on topical Kota and a topical potent steroid. So for potent steroid, they should not NICE recommend that they should use continuously for 8 weeks, okay, and aim for 4-week break. But if it's a very potent, then you should not be used continuously for more than 4 weeks. Again, patients should aim for the same 4-week break. So break is the same 4 week. But if it's very potent steroid, they should use it for only continuously for only for potent. They should use it for 8 weeks, and for very potent for 4 weeks.
Okay, maybe that's why I was mixing it. I know what is 4-4. So the very potent is
very potent is 4-4.
Demovate.
Yes, the Demovate, the one that prescribed by dermatologists, or clobetasol propionate. Yes. Okay. All right. So continuous use can cause irreversible skin atrophy and striae, systemic steroid side effects, or psoriasis to become unstable. Other topical therapies such as Kota or vitamin D analog could be used to maintain control when not using topical steroids. Psoriasis management, these are just states, I think. We're taking it in aliquot so we don't slip up. 34-year-old woman present with rash on her face. She's been feeling generally unwell for around 3 months with lethargy and has a variety of joint pains. What likely diagnosis? Impetigo, acne rosacea, systemic lupus erythematosus, sarcoidosis, perioral dermatitis. This is SLE, isn't it?
Joint pain, yeah.
Yeah, because she's having systemic symptoms. So SLE, the image shows a malar butterfly rash. Characteristics of this condition often accompanied by systemic symptoms like fatigue, joint pain, and a general feeling of being unwell. As described in the term of the question, SLE is an autoimmune disease where the body immune system mistakenly attacks healthy tissue in many parts of the body. So manifestation is photosensitive butterfly rash for SLE. Manifestation is photosensitive butterfly rash, discoid lupus, alopecia, and livedo reticularis net rash. And this is some of the symptoms. You can get this one. This looks a bit ugly, or this neat one. 67-year-old man who is a retired builder present following the development of a number of red scaly lesions on his forehead. These were initially small and flat, but are now erythematous and rough to touch. Was diagnosis: pityriasis versicolor, seborrheic keratosis, polymorphic light erosion, actinic keratosis, malignant melanoma. So that is actinic keratosis, isn't it? Yeah. So the most likely diagnosis of 67-year-old retired builder present with red scaly lesion on the forehead is actinic keratosis. Actinic keratosis are pre-malignant lesion caused by chronic exposure to UV light, typically seen in a fair-skinned individual and those with a history of outdoor work, such as builder. The appearance of these lesions as erythematous rough patches is consistent with actinic keratosis. In some cases, they can progress to squamous cell carcinoma if left untreated. So this is this is the picture here. Actinic keratosis is one of the more ugly one. The treatment, prevention. So prevention of further risk like sun avoidance, sun cream, fluorosil cream, typically a 2 to 3 week course can be used. Skin will become red and inflamed. Sometimes topical hydrocort is given following fluoride acid to help settle the inflammation. Topical diclone may be used for mild actinic keratosis. Moderate efficacy but much fewer side effects. Topical imiprimol trial have shown good efficacy. Then you can do cryotherapy and curettage. So management, sun exposure is the first thing. Fluoride acid cream can be used. Topical diclofenac may be used. They have moderate efficacy but fewer side effects. Then topical imiquimod can be used. Trial have shown good efficacy. Then cryotherapy and cautery. A 30-year-old woman attended the GP presenting with a long-standing wart, and she would like it removed because she's worried that it might turn into cancer. Grandfather died last year of malignant melanoma, and the father also has some skin cancer removed last year, but she cannot remember what kind. What's the likely diagnosis of this? Cutaneous squamous cell carcinoma, hemangioma, histiocytoma, dermatofibroma, seborrheic keratosis, verruca. This is looking like dermatofibroma or histiocytoma. Image shows solitary uniform nodule around 10 mm in size with overlying skin dimpling, which is histiocytoma. Skin dimpling, even though I didn't see much of the skin dimpling though. Okay, so that's about that. So these are the pictures of dermatofibroma. Dermatofibroma, also known as histiocytoma, they are common benign fibrous skin lesion caused by abnormal growth of dermal dendritic histiocyte cell, often following a precipitated injury. Common area include the arms and legs, solitary firm nodule or papillary nodule, typically on a limb, typically around 5 to 10 mm size. Overlying skin dimples on pinching the lesion. And these are the pictures you can have for dermatofibroma. Okay. The next question belongs to a 48-year-old woman that presents for review after a successful laparoscopic appendectomy. She feels well, has no complaint. There are linear well demarcated discoloration on the forearm and scalp. The patient is indifferent to this lesion and has a history of severe anxiety and depression. A point biopsy is taken that reveal non-specific things. What is the likely cause? Atopic dermatitis, cutaneous T-cell lymphoma, dermatitis artifata, lichen planus, pemphigus. This is dermatitis artifata, isn't it? Where demarcated skin lesion that appears suddenly with a labile indifference is.
How did you know it? I've never heard of dermatic artifata before.
So usually they will have psychological problems going on in the background, and then they are not bothered about the lesion, and then it just appears suddenly. So here now they say that she has successful appendix. She feels well and has no complaint. On exam, there are linear well demarcated education on the forearm and scalp. She's indifferent to them and has a history of severe anxiety. So the giveaway is the well demarcated discolorations on the forearm and scalp. People can easily scratch their forearm and scalp, isn't it? And then she's indifferent to the lesion. That was the giveaway for me. Then to also give it away, they now said point biopsy is taken that reveal non-specific finding. I'm sure they will not give us that detail in the exam because that is like a total giveaway. So they will not give you detail of biopsy, but they will give you that history of anxiety. They can give that history of anxiety and the patient and this and the well demarcated lesion, and then the patient being indifferent. But they will be too kind to still tell you that biopsy showed nothing. That's what. So most of the questions in the exam, right? You just have to pick on one thing and work with it, because most of the questions you'll be like, oh, I wish I had more information. So that 1-year-old woman developed painful purple lesion on her shin. Painful purple. Which one of the following medication is most likely to be responsible? Montelukast, lansoprazole, COCP, sodium valproate, carbimazole. This is a lichen. Okay, painful purple lesion. Yeah, no, it's not lichen. Is it? Lichen planus is not painful. It's not. Yeah, is it painful?
Lichen planus.
Lichen planus is purple, pruritic, papilla. Papilla, is it painful? Purple 5P, purple, pruritic, papilla.
But what would that be the?
I will still try COCP, but let me know what the diagnosis is. It's erythema nodosum. So this patient symptoms suggest that she's suffering from erythema. Yeah, just that COCP too can cause erythema nodosum. Yeah, so it's not the painful purple lichen planus is not painful. So patient symptoms suggest that she's suffering from erythema nodosum, right? Which is a type of panniculitis. That is it. It's not wrong. I am telling you.
It's strong. It's strong.
It's strong, exactly. And that's how the exam questions will look like. Yes. No information. That's how the exam question will look like. Exactly like this. So painful purple on the shin is enough for you to know that this is erythema, because number one, the shin area and it's painful and it's purple is enough for you to know that this is erythema nodosum. So the patient's symptoms suggest that she's suffering from erythema nodosum, a type of panniculitis characterized by painful red or purple nodules. Painful red or purple nodules on the shin. Condition can be triggered by several factors, including certain medication. One of such medication is COCP. It's well documented in medical literature that COCP can induce erythema nodosum due to hormonal changes. So look at the causes of erythema nodosum. Infection, streptococci, tuberculosis, brucellosis. So infection is streptococci, tuberculosis, brucellosis. Systemic disease, sarcoidosis, inflammatory bowel disease, and Behçet's. Malignancies and lymphoma. Drugs like penicillin, sulfonamide, and COCPs, and pregnancy. So drugs, you have the penicillin, the sulfonamide, and COCPs. Then pregnancy, then malignancy and lymphoma. Systemic disease like sarcoidosis, inflammatory bowel disease, and Behçet's. Then infection, streptococci, tuberculosis, and brucellosis. So these are some of the pictures. This patient complained of a painful spot on his ear. Which of the following statements regarding the condition is correct? It is twice as common in women as men. The peak incidence is in patients aged 40 to 50 years. It is more common in patients with diabetes mellitus. Biopsy is mandatory. Cryotherapy is a treatment option. It is not the chondrodermatitis helictis. So to be honest, I don't know which of them is correct.
When we see it, we read more.
Exactly. So when we read it, we see it. So twice common in women as in men. Peak incidence 40. Patient with diabetes, more common in patient with diabetes. Biopsy is mandatory. Cryotherapy is treatment option. I don't know. So cryotherapy is a treatment option is the correct. Cryotherapy is a treatment option. Patient condition based on the image description appears to be auricular chondrodermatitis nodularis helictis, known as Winkler's disease, which is a benign inflammatory process involving the cartilage of the ear. Cryotherapy can indeed be used as one of the treatment options for this condition. It involves freezing the affected tissue with liquid nitrogen that helps to destroy it and allow healthy tissue to grow back. So that past test, here you say you got it.
Yeah, I did.
Have you opened it? Have you launched it? we go launch them.
I did one question there.
How was it?
It was fair. It was okay. I wanted to test the metabolic that we have done today to see whether we still service. I just did one question there. It was okay. Except if you want us to do it today too.
Maybe we'll do it though. Before we go, let's run through the metabolic. Let's see.
Okay, anytime you're ready now. I've only done one. So.
Well, let's see how far we can just do small dermatology. We can leave it and just go and see the dermatology there. And also maybe we can also go into that your BMJ and just to have a look and make sure that yes, we are okay.
Just something to even think out of the box.
Exactly, that is different from what from what you a bit familiar.
Yeah, that's why I actually even did it.
Just to make sure. Yeah. So chondrodermatitis nodularis helictis is a common and benign condition characterized by development of painful nodules. So it's benign. That's why the answer I chose is wrong. Biopsy is not mandatory because it's benign. So characterized by development of painful nodule on the ear is thought to be caused by factors such as persistent pressure on the ear, secondary to sleep, headset, trauma, or cold. The chondrodermatitis nodularis helictis is more common in men with increasing age. Management: reducing pressure on the ear. Foam ear protectors may be used during sleep. Other treatment options include cryotherapy, steroid injection, collagen injection. Surgical treatment may be used, but there's a high chance of recurrence. So you reduce the pressure on the ear. Okay, can use foam and ear protectors Then other treatments include cryotherapy. So the cryotherapy can be used, steroid injection can be used, and collagen. So cryotherapy, steroid injection, collagen. Then these are some of the pictures here. Yeah. Yep. Okay. So the next question, the mother of a 4-year-old boy attend the surgery, frantically showing you a picture of unsightly lesion that have appeared on his body. She would like to know whether he needs to be excluded from school. You make a spot diagnosis of molluscum. So molluscum, no school exclusion. Let's move. No time. You are reviewing a patient with chronic psoriasis. Yeah. In the past, he's tried a combination of Beclo and Casipo that made little difference to his psoriasis. He then switched to Casipo trial monotherapy twice a day. Unfortunately, it's not help. On exam, he has plaque on his elbow and knees, which are around 6 to 7 cm. Following night, what option will you now discuss with him? Topical retinoid or Coal-Tar prep, Beclo twice a day. So what he has done, he's done Beclo and Calcipo, and he's done Calcipo monotherapy. So the next thing after Beclo and Calcipo, then Calcipo twice a day. The next one is now Beclo twice a day. Yeah, Beclo twice a day. Beclo twice a day or Coal-Tar or phototherapy. So I think Coal-Tar comes before phototherapy, Abi. I'm not sure.
I trust you.
My dear, don't try Dolapo. Dolapo, see your trust how we work. Coal-Tar come before UV. UV can also be used, but then it comes. So look at the arrangement here. Let's go to this thing. So after the vitamin D analogs, where are that? They didn't bring that their long story they used to bring here. So NICE recommend, where are they? So using, so they didn't give us the way they would normally give it. Look at it here, yes. So NICE recommends first line corticosteroid, second line vitamin D analog twice, third line then a potent corticosteroid twice daily or Coal-Tar. So Coal-Tar come first. Then after Coal-Tar, short-acting diphenol can be used before phototherapy. Phototherapy is a secondary care treatment. So phototherapy and systemic therapy with methotrexate as first line. Then after that, cyclosporin, systemic. I read this thing very well before exam that time, but now, when these people crash your confidence more.
But did question come from it?
Yes, I told you one straightforward came from psoriasis.
Okay.
One straightforward came from psoriasis.
Your reason was not always used.
Yeah, it was just one question. I was thinking that they're going to be embarrassing us with psoriasis, but they did not. They just brought the one picture, and then said that he has already tried betamethasone. What else will he be trying?
So that question, okay, then that one was sent. But if he has tried betamethasone, are you going down? You are going up.
No, if he has tried only betamethasone, you add Calcipo trial. So he takes Calcipo trial and beta in different day.
Okay.
Yes, which is what is here. Remember, so potent steroid apply once daily plus vitamin D analog is the first line. So he was still on corticosteroid, so I added vitamin D for him.
So what I'm saying, so what I'm saying is that there's the first line is combination.
It's a combination, but they gave him only steroid. So what will you do?
And so what if he was already in the third line?
How?
Whereby he's just taking the steroid only.
No. The question was straightforward. They say he was taking a potent corticosteroid, apply once daily. So if he's taking corticosteroid, apply once daily, you can add plus vitamin D analog. Yeah, some GPs just commence only steroid at a time. So because I get your point, the point you are trying to make is, what if he was already in the third line, which is a potent steroid twice daily up to 4. No, that is not where he was. Because if he was there, then we would have given him Coal-Tar, but they said he was taking it once daily. You get my point, right?
Yeah, I did.
No, that question was straightforward, even when they did the record with Oma, according to Happy.
Alright.
So 62-year-old with history of acne rosacea, present for, but I love the way you are reasoning. At least it makes us to pay attention to the details. So a 62-year-old with a history of acne rosacea, present for advice regarding treatment. Which one of the following intervention has the least role in management? So acne rosacea, camouflage cream, topical metro, low dose topical corticosteroid, laser therapy, use of some high factor sunblock. So this has a role, this has a role, this has a role. Laser and low dose corticosteroid. Do we use corticosteroid for acne rosacea?
I've never seen
Never
steroid
seen
before.
that. Yeah, so the answer is low dose corticosteroid. So in management of acne rosacea, the use of low dose topical corticosteroid is generally not recommended. This is because their long-term use can exacerbate rosacea, leading to steroid-induced rosacea or rosaceae dermatitis. Furthermore, abrupt discontinuation after prolonged use can lead to a flare-up of symptoms. Treatment of psoriasis. So you are reviewing a 46-year-old man with a known diagnosis of chronic plaque psoriasis. This is usually well controlled with over-the-counter emollients. Unfortunately, it seems to have flared up over the last week, and he has quite angry-looking patches of psoriasis over the knee. What would you prescribe? So what is taking? He has chronic plaque, and he's usually well controlled with over-the-counter emollients. So what would
They
you
have not
now
tried
do?
anything, just
Exactly. So emollient. So
Just
we'll do a combination
yeah.
of steroid and vitamin D, potent steroid plus a separate topical vitamin D preparation. Then this
Yep.
one is well controlled on over the counter. Unfortunately, it seems to have flared up, and he has quite angry looking, affecting his axilla. So this one is
Okay.
axilla. So this one for axilla we use a
We use moderate.
a potent topical vitamin D combined potent topical quota topical blah blah blah.
I can't even see the option.
Yeah, okay, so option here is a mild topical corticosteroid,
I
a
think that
a,
should
a
be a
potent.
mild
So
topical. Okay, continue.
so hold on, the axilla are thin, the face is the one we use mild or moderate,
Yeah, so
abi.
it's the same thing as the axilla too now. It's not just the face, it's flexures.
Flexura.
Flexures, yeah, flexures, genitalia, face, they're all kind of in the same group.
Which of them is moderate, which of them is potent? Moderate, potent, or potent?
Potent is the one you used up, the first question you used. So yeah, we use a lesser one.
I think there's this cap. Okay, is this cap that is, oh god. Okay, so let's go for the mind and I will correct that knowledge. So you are a 45-year-old man with a known diagnosis of chronic plaque affecting his hair, but it was seen by one of your colleagues 8 weeks ago, giving combination of this. Then he's been using this daily. Prior to this, he was only using emollient, and there has been some improvement, but you both agree that he needs further treatment to control his flare. Which of the following will be the most appropriate next step? So what is taking at the moment? Combination of vitamin D and a potent steroid. So what we are going to do now, we'll do where is that one? So if
Take
it's
vitamin D first, I mean.
he will do vitamin D twice daily, a topical
Yeah.
vitamin D preparation. So that mild is correct for what is the name of that stuff? The axilla. So let's go because that was confusing me. Which of them? So scalp is the scalp that you use potent. Yes. So I was mistaken.
Okay.
So it's the scalp. I know among those thin area, scalp you use potent topical
I always
corticosteroid.
say scalp is thin, though.
Okay.
Just
So scalp.
because the treatment of scalp is even the second line management
Okay, so it's not about being thin.
okay,
Yeah,
it's not even the second line,
maybe.
it's like the first line.
Yeah,
Just
maybe that's why it
yeah.
confused me. That's why it confused me because in my mind I put it as thin. Yeah. So potent topical corticosteroid, use once daily for 4 weeks. If no improvement, then either use a different formulation of potent steroid, for example, shampoo or mousse. So that's for the scalp. Now, Fledgora is one you use mild or moderate. Yeah, smashing. I think this is all. Then 23-year-old woman present for pre-employment screening, and she's to begin working as a nurse on an oncology ward next month and needs to be up to date with her vaccine. She has received all of her childhood and school age vaccines and does not recall having chickenpox as a child. Which vaccine does she most likely need prior to employment? So 23-year-old woman, this was that question I was asking you yesterday. I was looking for yesterday. So 22, but I let her Google it somewhere. The varicose vaccine and the viral whatever, they are two. They help to prevent the chickenpox primarily, the one given for employment. Then the Zostas vaccine are the one given to elderly people. So this patient is 23 for a pre-employment screening. She's to begin working as a nurse on an oncology ward next month and needs to be up to date with her vaccine. She's received all her childhood and school age vaccine and does not recall having chickenpox as a child, which vaccine does she most likely need prior to employment? Diphtheria, pertussis, and tetanus booster. Hepatitis A, influenza, measles, mumps, rubella, varicella vaccine. Do they need which of them are we giving them? Do we give
I'm
them?
just trying to remember the one we.
Mm.
Okay, well, it's almost the same thing. Do they need booster of MMR? I don't think so.
I think it's pertussis. I'm sure of pertussis for health workers.
Pertussis for
I don't know, but I don't know. It's like I don't even know.
Hepatitis, but they say hepatitis A, so that one does not look.
Varicella. Yeah. Oh God.
Oh,
Oh God.
varicella
Wait, is this not? I didn't see the varicella option. I didn't see the. I didn't see the varicella. Jesus. I was carried away, but I just talked about it here now.
I did not read the question well.
To be honest,
because I was thinking the way I used to remember it is all the vaccines they asked us in NES. They didn't ask us for all those DPT.
Yes.
Diphtheria.
Yes.
The one that they were asking us for was varicella. What else again? They asked us for again.
It's majorly varicella they wanted us to take, isn't it? But I just, you know what is even paining me is that I just talked about it, but I didn't see it. I just talked about it, but because it was at the last, I was carried away with all this their diphtheria. Because there's another one again, they say they give health worker. I don't know if it's H influenza. I think H influenza is another one they give health worker. Okay, varicella, that's the one I was saying that they give them very less or something. Okay. So look at it. Zostas is for chingos. That's the one given to elderly people. The health worker, varicella and vivus. I just talked about it. God deliver me. I told you that I went and read it. Nah, this witchcraft or what? Exactly. I'm trying to be. I googled it. I read it under NHS because after we talked about that yesterday, now I was telling you that there was one that we normally give to health worker, but it wasn't clear to us. So I now went and read it that yesterday when we finished, and I read about it that the varicella, okay, this varicella and the varivus, and varivus are the one given to health worker and that is for but that is against primary varicella infection, chickenpox. So, and they are given to health workers that are not already immune to varicella. Okay, then the contact of immunocompromised, example child whose parent is undergoing chemotherapy too. Then chingos is the zoster, and that was what I was just saying. So what I'm just wondering is why I didn't see this varicella. Holy Ghost fire. Maybe I will add prayer put in this exam well too.
No, but the thing is, because they were saying that she has been, so we thought that chickenpox is not. I felt that they say she has collected her vaccine as a child or something, so she didn't need chickenpox again, and they just wanted an additional one. It's not that when I now read the question, it now shows that she cannot remember when she
cannot remember if she had it. Yeah.
So they will probably need to give her.
Okay. Well, I'm not scared of failing during this practice though, because it's even good. I rather fail everything this practice, I'm telling you, than have false hope with 100% and go and fail. So 32-year-old lady attended with a facial rash for several weeks. 32-year-old lady attended with a facial rash for several weeks. She has a erythematous rash that looks greasy and has a fine scale over her face affecting her cheeks, nasolabial fold, eyebrows, nasal bridge and scalp. What's diagnosis? Acne rosacea, SLE, eczema, seborrheic dermatitis, psoriasis. This is seborrheic, isn't it? Erythematous rash, look greasy, have a fine scale.
No. Yeah, correct, sorry.
Look at the sebum area. An itchy rash that is affecting the face and scalp distribution is commonly caused by, what did you say gave it away for you?
Greasy.
Yeah, the greasy area, exactly. So erythematous, looks greasy and has a fine scale affecting the face, nasolabial fold, eyebrow, nasal bridge and scalp. That is seborrheic. And what is the treatment? Usually seborrheic, think about HIV and Parkinson. So for face and body, topical antifungal ketoconazole for face and body, okay, ketoconazole. Then topical steroid, best used for short period. It's difficult to treat and can reoccur. 21-year-old man present for follow-up treatment for moderate facial acne. He reports minimal improvement despite adhering to daily regimen of topical benzyl peroxide clindamycin combination therapy for the last 3 months. Prior to this, he used benzyl peroxide alone for 3 months, again without much benefit. So moderate facial acne, report minimal improvement despite adhering to daily regimen of topical benzoyl and clindamycin for the last 3 months. Prior to this, you use benzoyl alone without much effect. What would you do?
When you're tired, if you want me to continue.
Okay, no wahala. Like I'm tired. I'll let
I think we're doing how many today? 100, are we?
Yeah, 100. Then we'll see. We'll go through those your past tests and this
Okay.
thing. So, what is the most appropriate next step in managing the patient? Oral lamicycline and topical benzoyl adapalene, oral lamicycline and topical benzoyl clindamycin, oral lamicycline monotherapy. Refer to them and switch to topical benzoyl adapalene. So, this patient is 21, and what he has tried is the topical clindamycin and oral benzoyl. He has also tried the other one and it's not working. So, what are we going to do? Is it oral lamicycline and topical benzoyl clindamycin? No, we can't give this. You can't give topical and oral antibiotics the same time.
Oh, okay. That's
Yes.
smart. But I can't even remember this.
Yeah, you can't give together oral and topical. Oral,
so it's in there now.
yeah, then oral lamicycline, yeah, that one is making sense. Lamicycline monotherapy, then refer to dermatologist when there is scarring. Switch to topical benzoyl adapalene. So you need an antibiotic. He has already started antibiotics, so you need oral. So oral lamicycline and topical benzoyl adapalene. Topical and oral antibiotics should not be used in combination in treatment of acne. So that's about that one. A 50-year-old man that has had a cough for the past week developed a rash. It initially appeared on the arm, but is now spread to the torso. This is the picture. What's the diagnosis? Is this not a erythema multiforme? Mycoplasma can cause
No. Is this erythema multiforme?
Yeah, this is erythema.
Usually raised like
Yeah, this is erythema multiforme, isn't it? It's multiple.
Okay,
It's rare than. Yeah, it looks like erythema multiforme. But one of the causes, streptococci can cause mycoplasma, even COCP. Let's see the causes. Yeah, look at the causes here. Viruses, herpes simplex virus, like even the most common cause of can also cause it. It can be idiopathic. Yeah, look at it. Think. Yeah.
Yeah.
Then you can see it here. Look at it, can be quite raised. Then look, I think this is the one you may be used to here. This one and this one may be the one you are used to, but it can also appear this way.
How did they describe it? Did they okay, target lesions?
So they say develop. They didn't really describe it much, but the way they describe it here, the features target lesion initially seen on the back of the hands. So viruses, herpes simplex virus, idiopathic, mycoplasma, streptococcus can cause it. Drugs, penicillin, sulfonamide, carbamazepine, allopurinol, or NSAID. Oral contraceptive pill, nevirapine. Connective tissue disease like SLE, sarcoidosis, malignancy. The erythema multiforme major, the more severe form, erythema multiforme major is associated with mucosal involvement. A 40-year-old female patient with several circular patches of non-scaring hair loss to the scalp, which have appeared over the last 3 months. You diagnose alopecia areata and you discuss a wash and wait approach, but she's very upset by the condition and want to try treatment. Which of the following management option might you initiate in primary care? Dietranol, steroid, oral steroid, topical minoxidil, and refer for week. Do we do minoxidil in primary care?
Yeah, I will describe it last week.
They say it's corticosteroid. So let's see what they said about it.
Start with steroid first.
Start with steroid first. Okay. So now it's advised that if there is less than 50% hair loss, the option of watchful waiting should be discussed with the patient. Okay, as up to 80% of those with less than 40% hair loss will experience spontaneous recovery within a year. For patients in whom no regrowth, or when there is greater than 50%, or if the patient wishes to commence the treatment immediately, they can be referred to the dermatologist that may prescribe treatment such as topical corticosteroid. So it's even this thing that will now intralesional corticosteroid or topical immunosuppressant while awaiting the appointment.
Well, some GPs do that, child.
While awaiting appointment, or if a referral is declined, a course of potent or very potent topical steroid can be initiated in primary care. So a course of potent or very potent steroid can be initiated in primary care. Okay.
Don't give me minoxidil.
Yeah, so can be initiated in primary care. A 3-month course is recommended. Other management options recommended by NICE for primary care include the dietranol. Okay, so other management options are not recommended by NICE. Not recommended in primary care include minoxidil or referral for weeks. May be considered in secondary care. The guidance also varies according considering the need for psychological support like counseling. So minoxidil and datrianol is for secondary care. So, but we can commence while waiting or they reject their referral. Potent or very potent corticosteroid. Okay, all right. At least you have learned now. 28-year-old man present to his GP 2 weeks ago. He noticed an erythematous lesion on his abdomen. Since then, he's now noticed multiple similar lesions along his lower limb. He has not had anything like this before and is worried about a STI as he's usually had sexual intercourse with a new partner, and this is it. So he said his sexually transmitted infection screen is negative. Given likely diagnosis, what is the management? Conservative management, self-limiting, oral antibiotics, oral antiviral, surgical excision, topical antibiotics. This is discoid eczema, isn't it?
Really?
Yeah, that is discoid eczema.
Where did you get discoid eczema from?
So I know the way I used to differentiate discoid eczema, they don't have that central clearing when they are around like this. I don't know, make I see am first. May let's confirm that it is, but now I've forgotten what the treatment is. Do you know the treatment of discoid eczema?
Anything eczema, most likely steroid, but there's no even option of steroid here. That's why I don't think it's discoid eczema.
Okay.
It's not erythema, abi?
Let's see what it is. So the image demonstrates many red round patches on the skin. There is some silver scaling overlying it. The patient had present with a single rat started on the trunk has then spread to the body. Multiple ovoid or spherical erythematous patches with overlying scale. The silver white are this suggestive of pityriasis rosea. Hey, whoa, is it pityriasis rosea?
This past medicine self, they don't tire me.
As in, the other possible diagnosis is good temper, which represents similarly. I was actually thinking it was a good this okay. So that's pityriasis.
But how does that look like pityriasis rosea? Pityriasis rosea is Christmas tree appearance.
Exactly.
Emerald patch. Exactly. Didn't even mention anything like that.
That's how the exam will be. So I'm not surprised.
Somebody knows pityriasis rosea. That's rubbish.
So pityriasis rosea. Alright, so self-limiting usually disappear after 6 to 12 weeks. Let's see the question again. So 28-year-old man comes to the GP. He noticed a erythematous lesion on the abdomen. Since then, he's now noticed multiple there was a Herald patch now. Look at it, he noticed a erythematous lesion on his abdomen. That's the Herald patch. Since then, he now noticed the multiple similar lesions along the lower limb. Is the limb one they show?
This is like exam question.
Yes, that is it. Past medicine does it. That's why the people that read the past medicine, they all passed. And if you know do this man course, they passed. A 22-year-old may present to surgery due to long-standing problem or bilateral excessive axillary sweating. 22-year-old may present to surgery due to long-standing problem of bilateral excessive axillary sweating. He's otherwise well, but the condition is affecting his confidence and limiting his social life. What is the most appropriate management? Non-sedating histamine, topical hydrocort, perform thyroid function test, topical aluminum chloride, refer to dermatology. So we give him topical aluminum chloride, isn't it?
Yeah.
He's having so he's having hyperhidrosis. So the most appropriate treatment, so usually the treatment will normally give them aluminum chloride as the first line. Main side effect is skin irritation. Then after that, ionophorase is particularly useful for patients with palmar, plantar, and axillary hyperhidrosis. Then after that, botulinum toxin currently licensed for axillary symptoms. Then surgery, example endoscopic transthoracic sphenoidectomy. So aluminum chloride, ionophorosis, botulinum toxin, and then surgery, endoscopic transthoracic sphenoidectomy. Patients should be made aware of the risk. You are working in a GP practice and your next patient is a 50-year-old female. You note she was seen 1 week ago by a colleague who made a diagnosis of lichen planus on account of raised ishy flat top on papules on the flexor surface of both wrists. She presents today to tell you that the rash has spread to the mouth. On examination, you note a white lacy rash on the side of the cheek. White lacy rash on the side of the She complained of severe discomfort on eating or drinking, particularly spicy food. What is the appropriate option from the below to control her symptoms? Chlorhexidine mouthwash, benzodiazepine mouthwash, sodium lauryl sulfate toothpaste, hydrogen peroxide mouthwash, mycophenolate mofetil. So what is the patient having?
I think it's benzodiazepine, abi?
Because that's what we use. We say
discomfort.
with this benzodiazepine, yeah, benzodiazepine mouthwash is what we use for the, yeah, that is the answer. Benzodiazepine mouthwash can be used for symptomatic management of oral lichen planus. So management, potent steroid are the mainstay. Benzodiazepine mouthwash or spray is recommended for oral lichen planus. Extensive lichen planus may require oral steroid or immunosuppression. A 6-year-old present to the GP with a mother described a stubborn patch of eczema on the boy left cheek, which has worsened despite his usual emollient and topical hydrocort treatment. Overnight, the patch has become extremely painful and spread to his shin. He now had eczema since infancy. He has had eczema since infancy, but is otherwise well. An examination revealed a patch of dry erythematous skin on the right cheek and a larger, more erythematous rash on the left extending to the shin. The area is hot and tender on palpation. Vital signs are normal. What is the appropriate action? This child is 6 years. Okay? Stubborn patch of eczema on the boy's left cheek, which has worsened despite the usual emollient and topical hydrocort. Overnight, patch has become extremely painful. Is it the hepaticum he is now having? So we admit him.
That's what I'm thinking.
Yeah, let us admit him to pediatrics. He should go and get yeah. So an area of rapidly worsening painful eczema is an early sign of eczema hepaticum. So same day referral to pediatrics. Child is presenting with an area of rapidly worsening and painful eczema that is not responding to the usual treatment. This raises suspicion of and should be treated as eczema hepaticum. Eczema hepaticum is treated as a medical emergency. It can rapidly worsen and lead to systemic complications. Urgent assessment and treatment with antiviral are indicated to prevent eye and meningeal involvement. So this is the picture of example of eczema hepaticum. Okay.
It's bad though.
So eczema hepaticum. Oh my God, eczema hepaticum is severe primary infection of the skin caused by herpes simplex virus 1 or 2, more commonly seen in children that have atopic eczema. They will have monomorphic punched out erosion, circular, depressed, or serrated, usually 1 to 3 in diameter, as seen. As it is potentially life-threatening, children should be admitted for IV acyclovir. So a 25-year-old come with 2-month history. Woman present with 2-month history of following skin outbreak. She's been stressed recently and noticed it get worse during this period. No other part of her body are affected. Given the likely diagnosis, what's the appropriate initial treatment? Mild corticosteroid plus vitamin D, mild corticosteroid twice daily, potent corticosteroid plus vitamin D analog daily, potent corticosteroid twice daily. Refer. We've done this one. 72-year-old woman present to your clinic with a vesicular rash on the right axilla, vesicular rash on the right axilla for the last 2 days. He described a mild stabbing, burning pain in that area. On examination, you note maculopapular lesion with some vesicles and crusting. You diagnose shingles. What is the appropriate next step? Amitriptyline, naproxen, no treatment, oral acyclovir, topical acyclovir. It's topical acyclovir. The majority of patients with suspected shingles should be treated with antiviral. Please, what is the dose? That's another thing because
we're doing it in that class. It's 800 5 times daily. Did they put it here?
That's what I'm trying to check, but I don't think they put it here. They didn't put the dose here. Let me check for, if you can quickly check for BNF for the dose. It's important though, because they will not make it this simple as this question is. So let's say acyclovir for shingle, acyclovir, BNF.
They said 400.
For Chingo. Did you see for Chingo?
So this is
Herpes.
Yeah, it says 800. Yes, I was right. 800 5 times a day.
So 800 4 times a day for 7 days.
5.
I am seeing 4 in my own. What's happening?
Okay,
Okay, no, that one is post exposure. Yeah, post exposure prophylaxis of varicella zoster is 800 4 times a day for 7 days. Then varicella zoster chickenpox treatment and also herpes zoster chingo treatment 800 5 times a day for 7 days. Yeah. So take note though. If it's for post-exposure, it's 800 4 times a day for 7 days. But if it is to treat both chickenpox and shingles, it's 800 5 times a day for 7 days. 800 5 times for 7 days, okay? God will help us.
Then for genital herpes, it's lower dose. That one is 200 5 times a day.
5 times. What of oral herpes? Do they have oral there? We use higher dose for chickenpox because of those. So that for shingles and chickenpox, because of that post-herpetic neuralgia too. Okay. A 19-year-old man, he started on isotretinoin for severe nodulocystic acne. Which of the following side effect is most likely to occur? 19-year-old man, he started on isotretinoin for severe nodulocystic acne. Which of the following side effect is most likely to occur? Low mood, thrombocythemia, raised plasma triglyceride, reversible alopecia, dry skin. Which of them following side effect is most likely? So they have low mood, though they have dry skin for isotretinoin. So, but most likely is it dry skin because of the common.
I think it's dry skin.
Yeah, because of how common it can be. Dry skin is the most common side effect. Yeah. So the side effect of retinoid.
I think this came out in people's question.
That is it. Now that's why you saw me hiss now.
What did you choose?
I don't even know what I chose because I can't even remember the question. Adverse effect, teratogenicity. Female should ideally, these are the information that if I had used past medicine, it would be at my fingertip. I won't be struggling. I won't be struggling. So adverse effect, teratogenicity. Female should ideally be using 2 forms of contraception, COCP and condom. Dry skin, eyes, lips, the most common side effect of isotretinoin. Low mood. Why this is controversial topic? Depression. I think the question was on this mood because I knew about the dry skin and all that and the teratogenicity. It was a low mood I wasn't sure of.
Yes, so, confusing. But actually, they will put two options there. So, low mood and dry skin can occur, but I think the most common is the dry skin.
Okay, raised triglyceride can occur too. Hair thinning. Kaima! Is mommy, not daddy. So, raised triglycerides, hair thinning, nosebleed caused by dryness of the nasal mucosa. Then intracranial hypertension, isotretinoin treatment should not be combined with tetracycline for this reason, because of intracranial hypertension. What are you doing? Sorry, give me a minute. What are you doing, my love?
Oh, packing.
Okay. Do you want to make tea for me? Let me see what the time is, because I don't want to eat after 9. You want to make tea for me, okay?
Yes.
Thank you. Don't make it. Yeah, make it hot, please.
Yes.
Thank you.
Welcome.
So raised triglycerides, hair thinning, nosebleed caused by dryness of the nasal mucosa, intracranial hypertension, isotretinoin treatment should not be combined with tetracycline for that reason, and photosensitivity. So Dr. D, if I get to 50, can you help me with the other one so I will eat? I don't want to eat late. Okay. Dr. D, my network don't kick me.
No, yeah.
Yeah, if I get to 50, you help me, okay?
That's fine. No problem.
All right. So a 35-year-old woman present to our general practitioner with concern about painful skin on her leg that have developed recently. She reported that her medication was changed not long ago and anxious that these skin changes may be an adverse effect of the new medication. Upon examination of her leg, you observe this. What newly prescribed medication is most likely to cause the COCP, fluoxetine, ibuprofen, oxycodone, warfarin? I think COCP can cause this. What is this?
Is this not the erythema?
Yeah. Yeah, that's what it's looking like. So changes her medication was changed. So the woman come concerned painful. So it's painful. Yeah. So purple or red, painful on the shin. Yeah. So nodosum. So the image depicted erythema nodosum created by painful erythematous nodule on both legs. Among the various etiology, adverse effect in medication are known. So let's look at them again. Strep, TB, brucellosis, systemic sarcoidosis, IBD, Beckett, malignancy lymphoma, drug like penicillamine, sulfonamide, and COCP, as well as pregnancy. And these are the pictures. Let's look at it again. Erythema nodosum. There was one dermatology picture, my dear, that confused life out of me. The thing will just fool the persons from top of the back to the downside. I was trying to think. The options there were so confusing. I don't know what happened to me in that exam.
What kind of picture was it?
I have
Or
not.
what was
If I see the picture, I will let you know. I haven't seen it so far. So let's be going. That was how I
was
was.
there any diagnosis that was running through your head? But even if you see
Honestly,
the picture safe, it will be difficult for you to identify. You cannot.
no. If I see the picture, I will identify Dollar Park.
Did they take all their pictures from past medicine?
I don't think everything was from past medicine though. I don't think everything was from past medicine.
Yeah.
A 33-year-old man presented with a 3-month history of rash on the back of the hands. Okay, first notice on the knuckle, and it's slowly increasing in size. No pain, discomfort, or itch. He is well in himself with no history of weight loss or any bowel or urinary symptom. No personal or family history of skin condition. Is a bricklayer. You found this scratch. Okay, the lesions are not tender or palpation. Which of the following is most likely diagnosis? Tinea magnum, granuloma annuli, atopic eczema, subacute cutaneous lupus, dermatomyositis. Look at it here. These are annular.
Granuloma.
Yeah, granuloma annuli. Yeah, because of the look at this thing. The
Yeah,
what is
like
it called?
different annulars, they just come and join together.
Yeah. So granuloma annuli is a common inflammatory skin disorder characterized by annular, smooth and discolored purple and plaque. Affect any side of the body, tends to be asymptomatic. Those are surface of the hands and feet are most commonly affected, as illustrated by this case. Annula is more common in children and young adults, but can affect people of all ages. So, okay, so papular lesions that are often slightly hyperpigmented and depressed centrally. Yeah, because it's that depression I was looking at. Depressed centrally. Depressed centrally. That's what they will say.
Where's the pressure in this picture?
So if you look at this one now, you know this round one now. Look at the one on the right. That round, big round thing that now look as if he has a brain. Look at the center one is a bit depressed. Don't mind them, Jerry. A number of occasions have been proposed to the such as diabetes. There's only a weak evidence.
All right.
70-year-old retired teacher present to your clinic with concern about a lesion on the scalp. He first noticed it a couple of months ago and think it's hardly enlarged over this period. On exam, there is a 1 cm irregular scaly plex, 1 cm irregular scaly plaque, and you suspect an intraepidermal squamous cell carcinoma. You refer to dermatology who confirm diagnosis and recommend treatment. What is the appropriate first line treatment for intraepidermal squamous cell carcinoma? You don't see that kind of question I used to tell you. And they will not tell you that you refer to dermatology. Dermatology now, what will they do? That is one of the questions they will ask you. You waste your time, finish, they'll be asking you what dermatology will be doing.
Are you a dermatologist?
Exactly. So 5-fluorouracil, benzoyl-peroxide, imiquimod, photodynamic therapy treatment. So has he tried anything?
I think it's fluorouracil. He has not tried anything.
He has not tried anything.
Yeah.
So 5-fluorouracil is the treatment of choice for Bowen's disease. So 5-fluorouracil is first line treatment. So because they said here that, okay, on examination 1 cm irregular scaly plaque, you suspect intraepidermal squamous cell carcinoma. Okay, so Bowen disease is type of squamous cell in situ affecting epidermis, usually present as a red, scaly, crusted patch on sun-exposed area of the body. It has a low risk of metastasis. However, it can progress to invasive squamous cell carcinoma if left untreated. Therefore, early detection and treatment is required to manage and prevent progression successfully. This one is 6-year-old boy brought by the mom for hair loss. Mom is not certain of the exact duration of the symptom, and the child has long hair and often wears a hat. It was recently brought to her attention when the child complained of an itchy patch on the scalp. His feet and well, you notice this on the scalp. What is the likely diagnosis? Tinea capitis, seborrheic dermatitis, alopecia areata, folliculitis, capitis. Yep. 54-year-old man history of type 2 diabetes and benign prostatic hyperplasia referred to dermatology due to a number of lesions over his chin. On exam, symmetrical erythematous tender nodules are found. Symmetrical erythematous tender nodules are found. Lesions are associated to heal without scaring. What's diagnosis? Necrobiosis lipoidica, erythema nodosum, pyoderma gangrenosum, syphilis, Pyrethia myxedema.
It's necro. Are you sure?
So
I just erythema.
I'm coming.
Okay,
Type 2
good.
diabetes, benign prostatic hyperplasia, referred to dermatology due to number of lesions on the shin. On exam, symmetrical erythematous tender nodule. Is necrobiosis? Is it tender?
Yeah. No, it's not. I think you're
Yeah,
correct. You're correct.
it's erythema
I did not
nodosus.
even read this. I was
Yeah.
just thinking of.
Yeah, because of the diabetes, sometimes they'll just put the diabetes to confuse you, isn't it?
Yeah.
So it's erythema nodosum because from the description, and that diabetes can also be a cause of erythema nodosum, though. That's the truth too. Diabetes is also one of the causes. So where are we? So we are clear why is erythema. Due to the number of lesions on the skin, the symmetrical erythematous tender nodules are found.
And necrobiosis is like an ulcer. It's not a local kind of thing.
So it typically presents as yellow-brown atrophic plaque with telangiectasia.
It's a plaque.
Yeah, so typically presents as yellow-brown atrophic plaque with telangiectasia and a waxy appearance. While it's associated with diabetes mellitus, the lesions are usually non-tender. That's the tenderness that is a giveaway. Necrobiosis is not tender, and then tend to heal without scarring. So the lesions are usually not tender and tend to heal without scarring, unlike the presentation described in this case. Yeah. 67-year-old man is diagnosed with acne keratosis on the right temple. Acne keratosis on the right temple. Prescribed fluorouracil cream. 1 week later, he presents as the skin where he's applying the treatment has become red and sore. On examination, there is no sign of weeping or blister. What is most appropriate action? Continue fluorouracil cream within 1 week. Complete a yellow card. Stop fluorouracil plus prescribe topical hydrocort. Switch to topical diclofenac. Stop fluorouracil cream. I thought they said we can give them topical hydrochlor, but I didn't know you have to stop the fluorouracil.
Yeah, even me, I didn't know.
I didn't know you have to spoil it, and that is the only one that have corticosteroid. Exactly. Do you understand? Because I know you shouldn't stop it. It's a good question. It's a good exam question. So we won't stop it. You won't stop it. They just use it to tempt us. You won't stop it. You continue for 1 week. Let's see what they say. So continue fluorouracil cream plus review in 1 week is the correct answer because local skin reactions are an expected and necessary part of fluorouracil treatment for acne keratosis. The inflammatory response indicates that the medication is working effectively to destroy the abnormal cells. The described symptoms, erythema and soreness without blistering or weeping, represent a typical grade 1 to 2 reaction which is appropriate to continue through. Regular review is important to monitor the reaction and ensure it doesn't become too severe. So prevention of risk: avoid sun exposure. Cream typically 2 to 3 week course. The skin will become red and inflamed. Sometimes topical hydrocort is given following the say you see to help settle. That's what we thought. So you go read, you go know the answer, you go still fail am.
No, they confused us.
So continue to do the same review in 1 week. If there is no straightforward steroid cream to help, then we review in 1 week to see if it will stop. Which of the following antibiotics is most associated with development of Steven Johnson? Cotrimazole, ethambutol, chlorpheniramine, cipro, gentamicin. Cotrimazole, right?
Yes, it's awful. Yes.
Yeah, cotrimazole is associated. Hospital admission is required. For the rash is typically maculopapular with target lesion being characteristic but develop into vesicle opulo. Nicosis is positive in erythematous cases. Blister aeration appear when the skin is rubbed off. So Nikolsky sign is there in Steven Johnson syndrome and is also there in TENS.
They are practically the same things.
One is
more widespread in terms of percentage area.
Yeah, Steven Johnson is more widespread.
Yes. No. TENS is one that is more widespread.
Oh, TENS is one that is more widespread. Okay.
Yeah, it's more serious than Steven Johnson.
All right, thanks for that. 28-year-old woman with a history of idiopathic urticaria presents with a moderate flare of issue wheals. There are no signs of angioedema or anaphylaxis. She's been taking fezofenadine daily that has helped, but is struggling with troubling nighttime itching, which is interrupting her sleep. Which of the following could be considered? So 28-year-old woman, history of idiopathic urticaria, present with a moderate flare of issue wheals, no signs of angioedema or anaphylaxis. She's been taking fezofenadine daily that has helped, but is struggling with troublesome nighttime itching, which interrupt the sleep. What will you do? IM adrenaline, IM chlorpheniramine, oral cetirizine, oral chlorpheniramine. Well, let's give him this one, isn't it?
Yeah, of course, he needs to sleep. To say he's not sleeping.
Yeah. 75-year-old man attend on the day appointment booked by the duty doctor. Patient complained of right-sided severe chest pain, right-sided severe chest pain, fever and malaise that started 3 days ago. You note nothing of concern in his respiratory, cardiovascular and neurological exam. There are closely grouped red papules and vesicles on the right side of the chest, and the patient report that this is the site of the pain. What is the appropriate management? Advise the patient that is infectious until vesicles have crossed over, and prescribe because of antiviral, prescribe because of antibiotics, prescribe emollient, prescribe because of antiviral medication. Advise patient that is infectious until there are no more skin changes present. Advise the patient that is not infectious. So the answer is to advise the patient that is infectious until the vesicle have crossed, isn't it? That is
Yes, of
shingles.
course.
Infectious until the vesicle have crossed or 5 to 7 days following the onset of the rash. So please look at this picture. This is a basal cell carcinoma, isn't it? Which of the following statement regarding it is true? Curettage is an acceptable treatment option. They exhibit the Koebner phenomena. They typically grow rapidly. Bleeding is unusual. Metastases are present in 10% at the time of diagnosis. So which of them exhibit this Koebner phenomena? The one that when you do trauma
Yeah, that one
can
is
bring,
not in.
yeah. So
Huh?
the exhibit Koebner phenomena. Curettage is acceptable. I know that is a
I
scission.
think it's courage.
It
No,
is
I
a
think courage is part of what they
can be
do.
used, but curettage can be used too.
But
But
if you use elimination measure,
bleeding is not
they don't exhibit
unusual.
governor.
Metastasis is not in
They grow very
10%. They don't
slowly.
typically grow, and
So that's
so
the
it's
only
just
answer.
this Koebner phenomenon. Yeah.
No, not governor,
No,
courage.
no, no, no. Curettage is what I chose. I say I'm trying to say that
Yeah.
Koebner phenomenon that is not BCC that exhibit it.
Mm.
So BCCO is one of the three main types of skin cancer. Lesions are also known as rodent ulcers and characterized by slow growth and local invasion. Metastases are extremely rare and is most common type of cancer in Western world. Features: many types of BCC are described. Most common type is nodular BCC, which is described here. Sun exposure site, especially the head and neck, account for majority of lesions. Initially, a palely flesh color purple and telangiectasia may later ulcerate and leave a central crater. So routine referral, surgical removal, curettage. So curettage can be used. Cryotherapy can be used. Imiquimod and fluorescein radiotherapy. So surgical removal is number one. If there are multiple options there, then but curettage can also be done. Cryotherapy can be done. Radiotherapy can be done. Creams can be used. A 7-year-old boy with a history of atopic eczema is brought to the surgery. God bless you, my love. Thank you so much. Can you keep it there for me? Thank you. So a 7-year-old boy with history of atopic eczema is actually the bread is there, right? Is it there? The wheat bread, check.
Yes.
Is it there?
Yes.
Okay, thank you. So a 7-year-old boy with a history of atopic. Kaima, did dad buy another wheat bread?
Yeah. No, I don't think so.
Can you check if he bought it? Bring new one for me and take this one downstairs. Sorry, D. A 7-year-old boy with a history of atopic eczema is brought to the surgery. Overnight, he has developed a painful blistering rash affecting his face and neck. His temperature is at 8.1. Which of the following is most likely to be responsible? Varicella zoster, Streptococcus pneumonia, pus virus, Staph aureus, herpes simplex. Is this not impetigo?
Is this hepatitis? Really? I was thinking hepaticum.
No.
Eczema hepaticum. It's not?
Ha. No.
Because it's episimplex that
Okay.
causes it. Yeah.
So why did it look crusted like impetigo?
It's also clustered like this too, but it won't be widespread like this. It's usually on one side.
Impetigo too that I saw in that man picture was widespread. Oh.
Like this too.
God,
but if you
God,
look
I
at
beg.
the story is history of eczema brought to the surgery. So
okay, maybe because of that history of eczema, because if there is history of
yes.
eczema, you are thinking of hepaticum. Oh God, I beg. God, I beg. Oh, I'm trying to look for the impetigo picture here. Yeah, but that is a good faith for me, so that look at it now. Let me show you the picture
Does
here.
it look like this too?
Yes, I want to show you the picture that confused me, so that it too will not confuse you. Stop sharing. But like you said, the history would have been a
Yeah, the
giveaway.
history.
the history would have been a giveaway. But if it's about the look of that rash still looked. Do you see it? It was still widespread. Do you see it? It's still it's still widespread. So this is the picture.
Is there hepaticum in this guy's stuff?
Let me see if there is hepaticum, because I know I looked through these pictures before exam, so that's why.
You were okay now. Sure, you know say you try, Sha.
I tried. I don't know. I don't know what happened. So painful.
I'm telling you.
So painful. Sometimes I just cry because I worked hard for that exam. So how can the past medicine, that not just going through past medicine, made me that destabilized? Sometimes I felt like I gave up too early. Sometimes I felt like maybe I should have just not gone with the mindset that maybe because I went with the mindset that I was going to see repeated questions. Was that why my brain shut down? As in, I was just, there's nothing I haven't reasoned on.
I think if the beginning was, like you said, was discouraging for you.
For me, and I gave up too early. Maybe gave up too early. I gave up, and then it made me not to give a good fight. You know, I told you there was a time I stopped doing anything. So some of the questions I was supposed to have gone back to, I didn't go back to them again because the exam, I didn't want to continue it. I felt defeated. So I didn't see the hepaticum here.
There's no hepaticum there.
It's fine, no problem. At least I've seen the history. The history makes a difference because those two pictures are the same, to be fair. But the history will make a difference. So past medicine. Okay, so yeah, all right. So herpes simplex, eczema hepatic is primary infection. So let me read the question again. So 7-year-old boy, history of atopic eczema, brought to the surgery. Yeah, atopic eczema. I think that was a giveaway, to be fair. Yeah, so this is the one I knew as eczema hepaticum. Are you seeing it?
Yeah.
So, but that was a good question for me. Please look at this. Which of the following is least likely to have a role in management? Sunblock, topical tacrolimus, phototherapy, topical ketoconazole, topical corticosteroid. What will ketoconazole be doing? This is vitiligo, isn't it?
Yeah.
So sunblock can have a role, tacrolimus can have a role, phototherapy and this. So no role for antifungal and vitiligo. So vitiligo is associated with type 1 DM, Addison's disease, autoimmune thyroid disorder, pernicious anemia, and alopecia areata. Management: sunblock for affected area, camouflage makeup, topical corticosteroid may reverse the changes if you apply it early. And there may also be a role for topical tacrolimus and phototherapy, although caution needs to be exercised with light-skinned patients. A 54-year-old man present with a brown velvety rash on the back of his neck around his axilla. A clinical diagnosis of acanthosis nigricans is made. Which of the following condition is most associated with this kind of rash? A 54-year-old man present with a brown velvety rash on the back of the neck around his axilla. A clinical diagnosis of acanthosis is made. Which of the following condition is most associated with a kind of rash? Hypothyroidism, psoriasis, non-alcoholic steatohepatitis, ulcerative colitis, and chronic pancreatitis. Which of them is associated with acanthosis nigricans?
They did not put the diabetes.
Exactly, they don't put our diabetes, they don't put our this thing. So
are you sure of your ulcerative colitis?
No, I just put it, come they look now, I'm not sure.
Can it be thyroid? It's not, Abby.
Hypothyroidism with acanthosis.
Choose anyone.
It is hyper, actually, you are correct. If I now for choose your
obesity and
and they are like autoimmune problems, isn't it? Maybe thinking about that way. So type 2 diabetes, gastric cancer, obesity, polycystic ovarian syndrome, acromegaly, Cushing's, hypothyroidism was there, familia, Prader-Willi, drugs, COPD, and nicotinic. So we were very conversant with our diabetes, actually. Obesity, I was conversant with that. So yeah, but PCOS, I was conversant with type 2 diabetes, obesity, and PCOS. Things like gastric cancer, obesity. God help us to remember. Familial hypothyroidism, honestly. Acanthosis nigricans. It's just to keep revising all these things, even in the morning of exam. Try and look through them. Which one of the following statement regarding Chingus, Zostabas is correct? It causes chickenpox in around 1 in 50 in the 500 individual. The following statement regarding shingles vaccine, Zostabas is
This is
correct.
the one you said is given to elderly
Yes, Zostabas is
Yeah.
elderly. So it causes chickenpox in around 1 in 500. It should be given to all 65-year-old. Most common side effect is generalized myalgia. It is an inactivated preparation for herpes zoster virus. It's given subcutaneously.
I think it's
Subcutaneously, because you said it. Yes, and you chose IM and it was wrong. So we said it's subcutaneous. Yeah. So meaning that is activated in a preparation is false. The common side effect generalized myalgia is false. Given to 65 is false because we say 70 to 79.
Yeah.
Causing chickenpox in around 1 in 500 is used to prevent chickenpox. I was thinking past medicine will speak that their English so that we'll see use it and correct the other option. Yeah, but they didn't do that this time. All right, the next one is a 24-year-old man developed multiple teardrop purple on the trunk and limbs. So 24-year-old man developed multiple teardrop purple on his trunk and limbs and is otherwise well. The lesion cover less than 10% of the body. The diagnosis of goutte psoriasis is suspected. What is the most appropriate management? Oral penicillin for 14 days, reassurance plus topical treatment if lesions are asymptomatic. Oral pen for 14 days plus topical treatment. Abeg refer, abi? Because they say it's okay, it's less than 10%. No, it's the widespread one we refer.
Oh, okay. So just reassured and topical.
Yes, reassured and topical.
But if I didn't even know that there's 10% and not 10%. So I
yeah.
just thought that.
Yeah, the percentage of the body is important. I thought he said more than 10%. So reassural plus topical. Goutte is often self-limiting condition that typically resolve within 3 to 4 months without specific treatment. When lesions affect less than 10% of body surface area, topical treatment like Emollient, mycotic capoterol, first-line management. If lesions are symptomatic, patients should be reassured about the general good prognosis. Now, referral to secondary care is not necessary for uncomplicated goutte affecting less than 10%. Secondary care referral will be indicated if there was extensive involvement. Yeah, so you do referral if there is extensive involvement, significant impact on quality of life, or failure to respond to appropriate therapy. I know I read this one before my exam. Yeah, there's a general one. There's one question in GP self-test that is 18 was widespread, and the referral will be the answer.
Right. Okay. That's good.
Yeah. So most cases resolve spontaneously. Blah 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 blah. But we know that one. Let's move so we won't be bored. Mother bring her 3-year-old boy to the GP surgery. Mother bring her 3-year-old boy to the GP surgery. She said that she has noticed a few lesions on the hand. She said that he's completely well in himself and that she only noticed this by chance when giving him a birth yesterday. You diagnose viral wart and the mother asks you what the treatment is. Refer for cryotherapy. Prescribe a low dose topical steroid. Treatment not required that mostly will resolve spontaneously. Prescribe topical antiviral treatment. Prescribe salicylic. When did we say that we will refer them when they have a wart? When did we say that?
I thought we refer generally.
For what? That's what I'm asking. But this one they now say refer for cryotherapy. I think let's reassure. Notice
why do you want to reassure?
A few lesions in the hand. State that is completely well.
Because of the age?
Yeah, because it's just saying refer for cryotherapy. Cryotherapy, must it be cryotherapy? That's my problem. Where do you want me to choose the refer for cryotherapy? We'll try. I'm just not happy that they say refer for cryotherapy. If they say refer to secondary care.
If we do elimination method, because I think that's the new thing I've learned now.
Yes, so
like
salicylic salicylic acid is not correct. Topical antiviral is not correct. Low dose steroid
is not correct. So it's between these two things you just mentioned actually. When you say treatment is not required, those what usually resolve spontaneously?
Yes, they resolve spontaneously if it's that one. Okay. But they will say that if most cases of rash should be referred to, but they resolve spontaneously. Okay, so yeah, the question the what are not causing any problem, and therefore there's a strong case to reassure and advise that treatment is not required. There is no benefit in prescribing topical antiviral treatment or steroid. Cryotherapy and topical salicylic acid treatment are visible options. But as the what are not causing any problem now, the best option is to wait and see. The answer therefore is that treatment is not required and will resolve. Yeah, because somehow how will you just refer 3-year-old for cryotherapy just for viral what? So what are common and do not require treatment or less painful, unsightly, or patient requesting treatment for persistent one? Most of them will resolve spontaneously within months or at most within 2 years. In adult, it can take up to 10 years. 48, 54-year-old patient, 7-day history, painful rash on the lower back. He saw you 4 days ago and was given a course of acyclovir for shingles. Pain, however, remained debilitating despite paracetamol, ibuprofen, and amitriptyline. Pain is described as severe burning pain that is associated with a mild itch, is affecting his sleep and daily function. On exam, temperature is 37. Rash is on the left lower back that is characterized by closely grouped red papules and vesicles surrounding erythema. So, what is the management? Is it chlorpheniramine, flucloxacillin, fluoxetine, morphine, prednisolone? So, on examination, temperature is as I said, the rash is at the lower back, characterized by closely grouped papules and vesicle surrounding erythema. So, this man basically now, he has already had a lot of medications, Abby. From elimination, it's only prednisolone now that is remaining here.
Right. I didn't know. Did they use prednisolone for shingles? That would be a good thing. I didn't know that though.
Yeah, they say sometimes you can give it to like reduce inflammation.
Yeah, okay. Refractory.
So corticosteroid, because he's already had a neuropathic pain med, which is why it's not there. So corticosteroid can be used in refractory pain, in shingles, if simple analgesia and neuropathic analgesia do not help, but only for acute shingles. So it can be used in refractory pain in shingles if simple analgesia and neuropathic analgesia do not help. Yeah, I know I also read it before that our last test, and many things we read. It's just that when person dey unlucky like this, it will be like say you dey foolish. So, a 28-year-old woman with a history of psoriasis, present with dandruff and an itchy scalp. She's tried using Head and Shoulders with limited effect. A photograph of the scalp is this. Psoriasis, it has a history of psoriasis, dandruff, and itchy scalp. Use Head and Shoulder, limited effect. What is most appropriately first line? Cold type based shampoo, ketoconazole based shampoo, topical Beclo, topical calcipotriol, corticosteroid. So we'll give potent steroid for scalp, isn't it?
Oh, is this in the scalp? Is that what they said? It's in the scalp, Abi?
So yeah, look at the picture here. The picture is showing like flake in the scalp as if he's having a feel of psoriasis, and he has a history of psoriasis. Yeah, so I'll be thinking of Beclo because we just said that for scalp psoriasis you should do Beclo. Yeah. So scalp psoriasis, first line treatment is topical corticosteroid. Okay.
Did you say how long we're gonna give it? Is it 4 weeks or 8 weeks?
I think for scalp it's 4 weeks. It's part of. Let's see. Yeah, let's have a look. I'm not very sure.
So 8 weeks.
So scalp, NAS recommend potent, for his 4 weeks. Potent corticosteroid daily for 4 weeks. Okay. Potent corticosteroid daily for 4 weeks. All right. And if no improvement after 4 weeks, then either use a different formulation of that potent steroid. Okay.
So scalp is 4 weeks. Flexures, genital is 2 weeks. All right, that's fine.
All right. So scalp is 4 weeks. Yeah. Then genital, flexura, face flexura, and genital is 2 weeks. So we give it for 4 weeks. Then use a different formulation of potent steroid, maybe like shampoo or mousse if the other one is not working. Now, I recommend offering a mild to moderate potency corticosteroid. Apply once or twice daily for 2 weeks for face and flexura. Okay. 16-year-old female with a background of asthma is brought in by her concerned mom due to the appearance of a rash on her arm. This came on overnight and is non-pruritic but slightly tender. The patient doesn't know how it could have happened. She denies using any new product or any history of trauma. Her mother also voices concern about the child's school grade falling. This came falling recently. On exam, there are well-demarcated linear lesions that form geometrical shapes on the left forearm and palmar surface of the hand. The patient appears well and exam is unremarkable. What's the likely diagnosis? Dermatitis atifata, dermatitis herpetiformis, eczema herpeticum, excoriated acne. So did you see the catch for that question? It came in overnight.
This is your dermatitis
ativatus. Yes. So psychology. Yeah, look at this picture. 30-year-old man investigated for recurrent nosebleed and iron deficiency anemia. You notice a number of erythematous lesions on his skin. What's likely diagnosis? Peutz-Jeghers syndrome, alcohol excess, hereditary hemorrhagic telangiectasis, hemophilia, idiopathic thrombocytopenia. This was our exam question. Oh. I think I'm remembering. I am remembering seeing this kind of question that they open hand like this. They open the hand like this, eh? They just open it. You just like see the hand that's wipe everything on your brain. Hey, God.
Deficiency anemia.
So, Dr. D, yeah, close to our exam, dermatology is the last thing again we'll revise. These people, they like pictures. I'm not, I do not, I kid you not, Dr. D. They love pictures. Now, so they go bring her like this, they go shower them for your face. Piam, you go confused. Okay. So, what is this? What do you think is it? Because I think I saw this question in my exam. I am thinking.
But the reason why I will go for, I'm thinking is Peutz-Jeghers.
So the person is investigated for recurrent nosebleed and iron deficiency anemia.
Nosebleed.
Let's try Peutz-Jeghers. It's hereditary hemorrhage.
All right, because it doesn't just look right. All right, that's good.
This question came out in exam. Exactly. I remember the hand open, a picture. I became confused, totally out of it. I was like, what is this now? I didn't. And this
depends on the story again.
Yes, and this is not in that dermatology picture. You understand? I was so unlucky in this exam because I said I went through these pictures, like I went through them, check treatment, So another picture that they brought, there was another picture again that they brought like that. It was looking like a keloid, a mild keloid. That's another picture they brought. It wasn't in that pictures again. So that particular material is not all encompassing.
It can't be now.
It's not all
the same person doing the question. So.
Yeah, it's not all encompassing. So hereditary hemorrhagic telangiectasia. Let's see. The correct answer is hereditary hemorrhagic telangiectasia. The condition also known as Osler-Weber-Rendu syndrome is a genetic disorder characterized by abnormal blood vessel formation in the skin, mucous membrane, and often in organs such as lung, liver, and brain. The erythematous lesions seen on the skin of this patient are likely telangiectasias, small dilated blood vessels near the surface of the skin. Recurrent nosebleeds like epistaxis and iron deficiency anemia due to chronic bleeding are common manifestations of this condition. So, hereditary telangiectasia. So, is Osler-Weber-Rendu autosomal dominant? Multiple telangiectasia over the skin. What did we say was the difference between spider nevi? We say center, liver. You move from the center. Yeah, you feel from center. Then what's the one we are comparing it with? Spider nevi and which one again?
And telangiectasia.
And that's this same telangiectasia, yeah, Abi? So this, and you can see those tiny stuff, the telangiectasia there. Dr. D. Okay. Oh yeah, this small for me. Make I drink my tea.
Yeah, sure. 18-year-old female prevents her GP scalp hair loss. Which one of the following condition is least likely to be responsible? Porphyria cutanea, discoid lupus, tinea capitis, alopecia areata, telogen effluvium. So I think it's Porphyria cutanea.
What does that one cause?
Which one? The telogen?
No, I mean what does Porphyria cutanea?
They say it's least likely.
Least like this telogen effluvium. Is it? Yeah. Does it cause hair loss or used to treat hair loss? Which one?
It used to cause it. My wife even had it. People that give birth, pregnancy, that their hair will be falling down. This is what they call it.
Okay, that's what they call the telogen.
Yeah, or if you undergo stress and you just believe that your hair will be falling, you'll be losing your hair.
Are you serious?
So most likely it's pregnant women.
Yeah, thanks for telling me.
Once they are pregnant, after pregnancy.
After pregnancy, the hair start falling, my dear.
Yeah,
pregnancy deals with us women in a different way, different way.
I'm telling you.
My own, If you see how my body they be when I get pregnant, with black spots. That
it's not polyformy eruption.
It's not any polyformic. My face, everywhere, my back. It just clears on its own after the pregnancy. I don't know what it is.
Yeah.
It is black spot, black, big horrible pimples.
with your fair skin. You can't be like
If you see how I dey be,
Mama Gagu.
if you see how I dey be for pregnancy, you go pity my generation. But the good thing is that I'm lucky, everything resolved. But you see this thing like stretch mark, I know they get them. My
Your skin no dey expand.
my body will still be like person will never do anything. I no get like that kind of stretch mark with pregnancy they give people. No. Yes.
That's good though.
Exactly. Is that pimple? For my back, it will full my back. Now so my husband go dey press am. Very bad. But it resolves completely. That is the good news. And it didn't leave much mark. I think it's the back one that may have 1 or 2 mark left.
I
Okay.
think is that not the polymorphic eruption? Is that those action? I don't know.
That polymorphic eruption was not looking those nodules, so it wasn't looking nodular. I like to think it's acne.
Acne, yeah.
I just think it's acne. Okay, go on.
So let me just read the this condition really affects the scalp. It causes photosensitivity, skin fragility, blistering on sun-exposed area, particularly arms and face. Can cause hypertrichosis, excessive hair growth, particularly on the face, and does not cause hair loss.
So it causes excessive hair growth.
Yeah.
So telogen, discal lupus, tinea capitis, and alopecia, they will cause hair loss. Okay.
Yeah. It's okay. Let me take it out. Just 1 second, Eugenie, come Right, so 33-year-old fit and well comes to see you with an itchy rash. She's 30, pregnant with twins. This is her first pregnancy. The rash started on the abdomen and it has particularly affected her stretch mark. On examination, she has urticaria papus with some plaques localized on the abdomen. The umbilical region is paired. What is the most likely diagnosis? Psoriasis of pregnancy, pemigod, obstructive cholestasis, polymorphic, atopic eruption of pregnancy. Right.
Polymorphic eruption.
Because of the sparing of the umbilicus, Okay. So this polymorphic and pemphigus. No. Pemphigus and pemphigus. What's now is it the mucosa but both of them affect the umbilicus, Abi?
No. Pemphigus will spare the umbilicus. And though happens second and third trimester, like that woman is still going to third trimester.
Yeah.
Polymorphic eruption will start from stretch mark. Like they said, it started from stretch mark. And then it will not affect, it will spare the umbilicus, like that the umbilicus is spared. But the atopic eruption will just like eczema. That one is just eczema.
Which one affects the oral mucosa?
It's pemphigus.
It can occur in pregnancy too, Abi?
It can occur in pregnancy, but they will not tell you that there's a mucosa involvement.
Okay, right. That's what I was just trying to. So, polymorphic spares the umbilicus, right? Just in reaction to stretch mark. Okay. So, 82-year-old patient attends at GP due to rash that has developed over her anterior thigh in 3 weeks. She said that it's not painful or itchy, but she's concerned that it does not blanch with the application of the glass test. She states that she has had some flu-like symptoms, so I spent some of her time in the chair under her many blanket and the hot water bottle on her lap. On examination, you notice that the patient has a well-demarcated mottled erythema that appears like a net-like across the thigh. What is the most likely diagnosis?
That's that
I think with the okay, because of the fire, the hot water stuff. All right, I think we can move. Yeah. So select the answer. The parent of the most appropriate topical treatment. The parent of an 8-year-old girl have noticed a small growth on the sole of her feet for the last 3 months that has become painful. On examination, there is a small firm hyperkeratic growth with tiny overlying black dots on the sole of her feet. I mean, where is the sole again?
The sole is where you dey match for ground.
Okay.
Mm.
On examination, there's epikeratic growth. What could that be actually?
Mm. Mm.
And it's not painful. Except amulorephin is for fungi.
Mm-hmm.
I don't even think that diclofenac is for anything. Malathion is for permethrin or species. Fusidic is for what do you call it again?
Should we try diclofenac? I don't know.
Diclofenac.
Diclofenac gel. I don't know what that is.
The tiny overlying black dot. I will be so interested to know the answer of this one. Small growth on the sole of our foot. Oh yeah, now let's so we don't waste time. Could it be? 76-year-old man, long-standing patch of rash, itchy skin on the scalp, which has not changed in the size. On examination, 1 centimeter erythema and some scaling, which is rough in texture, with surrounding sun damage. This solar keratosis or something, actinic keratosis. So we usually use it's not fluorescent, is it there? Or if not,
diclofenac.
yeah. I don't think that 55 will be diclofenac. I don't know what to choose, to be honest. And so,
we never enter her. No worry.
Parent of a 6-year-old girl noticed that she's been scratching her hair. This one is lice stuff. Pubic lice. Let's speak malathion, or is it permethrin there?
That's permethrin.
All right.
Salicylic
I
acid.
wanted to say salicylic because that was the only odd one there. So it's a what? The child has a plantar warts.
Also known as verruca.
The tiny black dots are caused by thrombosed veins. They often self-resolve, but if treatment desired, topical salicylic acid for up to 12 weeks can be tried. All right. Verruca.
Okay. I think the other ones are species. Malathion is what they gave here. Why?
I thought permethrin was the first line, though. Okay. So it's dimeticone and malathion, not permethrin. Permethrin is scabies.
Oh, lice, not scabies.
Oh, but you know that they still use permethrin. I've seen answers that they choose permethrin too. This permethrin and malathion, they're just crazy set of people. But I think according to guidelines, it's either dimeticone or malathion, actually.
Yeah, okay. So for lice, let's go for malathion, dimeticone.
Yeah.
Do those ones first before we do any other one.
Yeah.
All right. Okay. We go do all right.
26 HIV positive developed seborrheic keratosis. Which of the following 2 complications are most associated with this condition? Alopecia and otitis externa, blepharitis, otitis externa, photosensitive alopecia, photosensitive blepharitis, blepharitis alopecia.
So, complication of the seborrheic dermatitis.
Right. I know it causes blepharitis, right? Doesn't cause photosensitivity.
No, I was just thinking, is it photosensitivity and blepharitis or blepharitis and otitis externa?
I was even thinking of alopecia.
No, there's no alopecia. I was just thinking the 2 photosensitivity and otitis externa and photosensitivity and blepharitis. I wasn't sure.
Okay.
The otitis externa and blepharitis are common complications. Let's see the complications. Where is the complication? They don't write them here.
No mind, they go set. Okay.
Well, look at it here, fissures. The otitis externa.
Lesion on the semen area cause dandruff, periorbital auricular nasolabial, foods, otitis externa, and blepharitis may develop.
Nah, man, these guys, this is very unfair. What these guys do is that they just like pick in between words.
Who is that? Did you pass my time?
No, the exam itself. So it's good. It's good that we were. That's the advantage of past medicine. Past medicine go through those in between lines and make you pay attention. All right, let's go on.
So you have 21-year-old woman who is 16 weeks pregnant, met with worsening acne. This is you.
As in, and I know they get acne on a normal day. Che, you don't see my face.
Your face fresh now.
On a normal day, I know they get acne. But once I'm pregnant, hey, jeez.
Maybe thank God now say at least now pregnancy type.
And to be fair, my face just wears, my whole face wear uniformly. There is no nodule. The nodules are on my chest and my back. My face will still be there, but ugly. My nose go come spread more.
Like rhinopoma.
As in, but then the nodules are usually on my chest and my back. So what's name asthma? Okay.
So 21-year-old, 16 weeks pregnant, worsening acne, which is finding distressing. She's currently using topical benzoyl peroxide, limited effect. On examination, there's widespread non-inflammatory lesions and pustules on her face. What is the most next step? Oral trimethoprim, lamicicline, erythromycin, topical retinoid, oral doxycycline. The only thing she can take there is
yeah, she's pregnant, so she can't. Let's just take care. Yeah, all this one. They got that she can't take it. Yeah, no small. This is SCC.
squamous cell.
This is SCC. Yeah.
Hey.
So this one was the one I was mistaken for that first legion. That's the one I was mistaken for that first legion we saw yesterday, the dermatofibroma we saw yesterday. So I went back and checked it and noticed that yes, so this one we have like a smaller one beside it.
Why SCC? Why not basal cell?
It's SCC. It's part of the pictures in the SCC because remember there was a legion that looked like it, but was only one yesterday, and we chose BCC, and the answer was dermatofibroma. So that was why I went to look for the picture. I know you will not see it as SCC. That's why I just went ahead and told you it's SCC. Look at it, it's even here. That's why I just went ahead to tell, so we don't waste time, because I know you normally you wouldn't say it's SCC. So just know it by the fact that there are multiple other ones surrounding it, just for the sake of this exam, in case they bring it. But the one of dermatofibroma will just be solitary. There will not be anything beside it. So they say why ganglion are obviously very common. A number of features are. Go ahead.
I'm not consistent with this diagnosis. Firstly, the appearance itself is atypical in terms of color and presence of a satellite lesion. The examination findings intradermal non-transcripting also points away from a diagnosis of ganglion.
What do they mean by that satellite lesion?
Isn't all those small things around?
Exactly, that's already. Let me just think. I just want to be sure it's what I know, because I don't even know what I know these days. Okay, let's move on.
21-year-old male presents with a new skin rash, appeared during summer, holiday spent backpacking, shows in multiple pale brown patches to the neck, upper chest, appears flaky, asymptomatic, is well. What's the first line? No treatment, topical steroid, is ketonaz as well. This picture,
yeah, this vesicolor. Yeah, let's move.
Yeah. 54, 2-month history of rapidly growing lesion on his forearm. Lesion initially appeared red purple, but in the last 2 weeks has become crater filled centrally with yellow brown material. He has a skin type 2. Lesion is 4 meter, morphological as described above. Likely diagnosis.
Wait, let me try. Don't hold on. I never get them. So it's 54, 2 months, rapidly growing lesion on the right forearm, rapidly growing, and it literally appears as red purple, but last 2 weeks becomes yellow material type. He has skin type 2, 4 millimeter. What do you think is it keratoacanthoma because of the rapidly growing?
Correct. Yeah, it's keratoacanthoma.
Because of the rapidly growing.
The rapidly growing. Slow growing. It will be basal cell.
Yeah, the rapidly growing was the giveaway for me. Yeah, they are both craters. Yeah. Okay.
But keratoacanthoma is within weeks to months.
Yes.
Basal cell takes a while to be growing. And that's why for treatment for basal cell, it's most likely routine referral self.
Yeah.
Except if it's in certain sites of the body, you cannot do 2 weeks.
Yes,
Like
I agree. And also the centrally filled keratin, if you know it, is also a giveaway. Rapidly grow to become a crater centrally filled with keratin. So that's another one. Okay. Sorry, let me see what was that last point they made there. Okay. I won't be submitting. So there's a last point there. They say spontaneous regression of crater within 3 months is common, often resulting in a scar. Okay, so such lesion, however, needs to be excised, yeah, because it's rapidly growing. All right, go ahead. This one is bullous.
Yeah, let's just. Well, how do you treat it now? Is this steroid?
We give but this one is looking widespread, so maybe a systemic steroid. Elderly man. So there's a potent topical steroid, but it's looking widespread. So don't know. Yeah, it's looking widespread. So many people went for potent topical steroid too, but because of the widespreadness, I would have gone for that. So the treatment is oral corticosteroid at the mainstay. Yeah, so oral are the mainstay, but topical corticosteroid, immunosuppressant, and antibiotics can also be used, but topical are mainstay, especially when it's now widespread like this. Can't be messing around with
it's either topical or oral, Abi?
Yes, but oral are the mainstay, like especially when they are widespread.
So in 2013, vaccination against shingles was introduced. What is the vaccination given for ongoing catch-up program? So ongoing catch-up program is 80 years now. It's not. That's the one that's more than 70, isn't it?
The catch-up programs, but which one? I thought it's 70 to 79.
We give it from 70 to 79, isn't it? Then we not give.
Because there's no 80. They say the evidence have shown that if you give it 80, there is no help. It doesn't help. It doesn't work. So the end
there's something about 80 years old.
Let's read now. Shebi na we dey here. More we read that. Look at.
They said in 2030.
You see where the 80 years here. Chingo vaccine is not available in anyone age 80 and over because it seems to be less effective. Yeah, that was all we read yesterday.
In addition, anyone who was eligible for in the previous 2 years for new start on their vaccination remains until their 80th birthday. Okay, so it's 70. Okay.
70 to 71. So what I want to know, why is the answer 77? Because the ages are I know it was not 70 to 80, but I was looking for 70 to 79. It's not there. Say when is the vaccination given? Ignore the catch-up programs. Okay, so 70. Yeah.
Okay, they say should ignore. But what's the catch-up program first?
So there is also a catch-up campaign. The following is taking place. So look at the catch-up campaign. Anyone age 70 can have Chingo vaccine. From September, the Chingo vaccine offered routinely to people 70 as a catch-up to those age 70. Okay, catch-up is to those age 78.
So they said the catch-up is from 70 to 78, right? But the main single vaccine is for those that are 70 years.
No. Look at what they're saying. They say will be offered routinely to people age 70. Routinely to people age 70. Then, and as a catch-up to those age 78.
Okay.
So
you become eligible for on the first day after you've turned 70 or 70. So they only give it twice, 70 and 78. Is that what you're saying now?
So the aim is to give it between 71 and 72, 70, 71, 72. You understand? And also people, because they say in addition, people who was eligible for previous 2 years, blah 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 blah. This include people that were 71 and 72 in this, and people age 79. So I think from my own understanding, you want to give it to them around that 70, 71, 72. But then as a catch-up program, you also give it to people that are 78 to try to give it to them before they turn 80. That is what I understand from everything they are saying here.
So if somebody is 75, nothing for them.
And yeah.
Is that what they are saying? People are not serious. So.
It is.
Because I had a patient that was 70. I can't remember it. Maybe 74, 75, asking for the shingles vaccine. So I don't even know what I would have told him if I had read something like this. I just referred him to the nurse.
That is the best thing to do. But I don't think if you are 75, they won't give you. I still think that 70 to 79. Yeah, so offer to all patients 70 to 79 can still have it. Yeah, 70 to don't mind them, but 70 to 79 can still have it on a nutshell. All right, let's move on. 18
All
year
right.
old.
18-year-old present with a widespread skin rash. Last week, he had a corrosive and a sore throat, which has not improved. The rash is not itchy, but is concerned about how much it has spread. On examination, you find out that his whole torso and upper legs are covered with teardrop erythematous shaped scaly. It is estimated that the prostate covers 20% of the body. What is the most appropriate? We say we refer now if it's more than
Exactly. Yeah, we'll refer urgently, isn't it?
if it's
Yeah.
more than 10 or
More
20.
than
What is
10% we
10?
refer them. Yes.
Stop that.
More than 10% we refer them for phototherapy.
All right, let's move. Like teardrop.
Yeah.
Which one of the following steroid cream is the most potent? Most potent. So it's going to be
Demovate.
Demovate. Yeah. Once we know, we don't need to read in all the options because
Exactly.
we're at time.
Because time, yes, and
50-year-old man.
we still have to go
Eh?
and see. We have to launch that your question bank. Oh. Better that
I'm ready
we
anytime.
launch it now before they will come back and tell us that all the questions were in past test. Because this exam is war. All the questions will not be in past test. Now GP self test have gas. Nobody is saying
I'm
GP
telling
self
you.
test now. October has scattered them. Everybody mouth is now closed. Nobody is even mentioning it.
At all, nobody's mentioning it again.
Everybody is angry with GP self test.
They should close that thing.
Don't mind them. The network was disturbing. I think the show. Are you sure?
A lot of people were.
Exactly. Are you sure it's not because of
A
the
lot
way
of
people were crowding the network? Then
I think that's why they say they will show them Pepe.
let us show these people Pepe.
The stuff was
Because
their site was just crashing and crashing and
many
crashing.
people were messaging them and complaining. They now decided to show us Pepe. Go ahead, Jare. We'll be
18-year-old
alright.
man rash on his penis. He's had a rash on his glans penis for about 6 months. It hasn't grown and is not itching, pain or discharge. On examination, shiny, moist, orange, red, well demarcated plaque. There are no pinpoint red lesions within the lesion. And surely, he is uncircumcised. What's the answer? Seborrheic, Zunn's ballantitis, lichen sclerosis, psoriasis, Sicily ballantitis.
Orange, where they're marketed in Glamben. Is it Zoom or Cessinate? Which one? Because this one is not looking sclerosis. Sclerosis is the one we say white. It's not white, isn't it?
Yeah, and I think sclerosis is itchy.
Do you want me to try sclerosis? Because I don't know what.
No, I don't think that's the answer. I'm saying that it's not sclerosis because sclerosis is normally itchy and this one is not itchy. Go with Zune.
Go with Zoom, okay. Yeah, Zoom is correct. Orange red lesion with pinpoint redder spot on the gland and adjacent. So what is the difference between this Zoom and Cessinate?
The only way we can know this zone is to see it. Do you want to check online?
Let's check. Let's see because they didn't put
just
it
type
here.
Zune
Cessinate
ballantitis.
is a chronic in men with Ritter syndrome, although it can occur in isolation where the marketed rheumatoid play with a ragged white border. So Cessinate will have a ragged white border. Okay, so let's say Zoom balanitis.
Are you working tomorrow?
I'm working, but it's fine. Don't worry yourself. I'm okay, my dear. I'm okay.
I'm not working tomorrow, so I can sleep anytime.
Okay, my dear, I'm not even bothered as I'm talking to you now because this is now a matter of life and death. So to be honest, I am not actually bothered. Even their lecture sef I no prepare am. I go open am, me and them go dey do am like that. I won't be a good lecturer tomorrow. Sorry to them. I won't be a good lecturer tomorrow. You notice like the other last lady that taught with me lecture. I'm sorry, but that is the what I may do. How will you go and teach students without going through the slide? Even this thing I'm talking, I can't even do it. I'll still go through those slides. So if there's anything, I'll just screen through them. If there's anything that is strange, I can quickly Google it. You understand?
Yeah.
I can't see any pictures here, oh my dear.
Of Zune ballantitis.
Honestly, not seeing any picture. You know this
All right,
people,
let's move that.
they too they hide their private, so they too they hide them. Let's go. Okay. So, but at least let's know from clinically what gave it away. from what they said here is that Zoom balanitis is orange-red region with pinpoint redder
No, but
spots.
what did you type? Because I'm seeing a lot of Zoom balantitis here.
Ah,
Are you
share
sure?
beg, make I see. I didn't see.
Type Zoom, ZOON.
Zoom. That is what I type now. I type Zoom. I bet share for me. I type Zoom pictures, images.
No,
Not seeing
just
it.
type Zoom in full, Zoom balantitis. Not just Zoom, no.
That's what I type. Zoom balanitis pictures. Zoom balanitis.
Ah, just type that. You don't need to say anything. Still the same thing, abi? Let me send you what I saw.
I bet send me what you saw because I'm not seeing anything that is making sense here.
When last did you speak to Indidi?
Yesterday. She
How
said
is she actually?
she said
I
that
don't know.
she has not read, that she's afraid. She want to read.
She's very emotional. I don't know. She said she's thinking. She's this.
I spoke to her. Ah, look at nice pictures. Spoke to her. She said that imagine me that read and work hard. That she doesn't know what happened to her. It's autumn. Oh, I see. I didn't see these pictures. Don't know where you saw it. So that is good. So this is a good picture, to be fair. Let her read. Anybody, any method you use, just use, my dear. So Zoom balanitis is present with orange, red. Yeah, and you can see that one you showed me is red. Prominent pinpoint redder spot on the glands and adjacent area of foreskin in uncircumcised men. So that is Zoom balanitis. Then did you see ceccinate? Did you see ceccinate? Then ceccinate is a chronic balanitis in men with Rita syndrome.
Yeah.
Did you
I
see?
sent picture too.
Yeah,
Yeah, that one is
yes.
white. It actually looks like.
Yeah. This one is very helpful. This Zoom you sent is very helpful. Hey. Wetin dey happen? Why am I not see it? Don't go back. I don't remove the WhatsApp now. Have you sent the ceccinate?
Yeah, it's like say you get two numbers. I don't even know where I send them.
Exactly. Don't send that to a different number.
Because this one looks a bit whitish. Like
I never get them.
I see ceccinate erosive palatinitis.
Okay. Which one is this one? Okay, ceccinate. Yeah. This one look a bit whitish, isn't it? Okay, so ceccinate 1. Ceccinate, they say, where is that one? Where is it? Ceccinate is a chronic balanitis in men with Rita, although it can occur in isolation, present with a
I
well.
don't even know say I don't leave group.
You don't leave. Let demarcated.
Did you see it?
Yeah, jagged border.
Yeah.
Yes, I've seen it. It has a jagged border, white border, and there's a white stuff there. Yeah, I've seen it. Thank you. I think he does.
Baby, how come pennies no dey show for your own? Did you block it or say no pennies? No, I see no pennies
My
for your
dear,
Google.
I don't know. I'm just surprised. I don't know what is happening.
Yeah,
Okay.
move.
All right, move. Yeah.
So
This one is a
45-year-old.
erythema nodosum.
Yeah.
They're asking for the diagnosis. What are they asking? What
What
comorbidity
comorbidity
is the rash
is the
associated
Rashmus?
with? Autoimmune hepatitis. This is where they normally get me. Non-Hodgkin lymphoma, palmoplantar. My dear, this is where they normally get me.
Wait, I should know this. Just wait. Polymyalgia rheumatica. Are you sure it's non-Hodgkin's lymphoma? Okay, they say lymphoma, systemic sclerosis. I think it's systemic sclerosis. So
The seizures of the general.
he has felt lethargic, loss of weight. Happy?
Hey, for leave me for my Hodgkin, not Hodgkin, where I don't choose. Oh yeah, let us go through the courses. Oh yeah, my dear, it's not your fault. If I am sure, I will not go with that one.
Okay, you actually, there was a time you read malignancy.
Yes, I say malignancy. So malignancy and lymphoma,
yeah.
That was why I went with it. Malignancy, I remember. I didn't remember the lymphoma. So malignancy and lymphoma infection, strep TB brucellosis. These people, once they miss your option, it will look as if there's a spirit. That spirit is what I have to clear before the exam. So malignancy and lymphoma is there. Strep, tuberculosis, brucellosis, there's systemic disease, sarcoidosis, IBD, Beckett, malignancy, lymphoma, drug penicillin, sulfonamide, COCP, pregnancy.
Should not have failed that question. 32-year-old lady, 16 weeks.
Yeah, we shouldn't have failed it actually
I
because
think we have done this one. Erythromycin, Abi.
what is this one?
She's pregnant. She has
16
got
weeks.
acne.
Yeah, so we give her erythromycin. Are you trying to pay for your sin? I bet life is not that serious. So, what's the likely diagnosis for this one? They are what they're asking. So,
Let me see
this
the
is
question.
looking. No, let's read the question. Yeah.
So it's slow developing. So this one is slow developing.
So it's
we're
50,
thinking
50. It's 50. See, let's start from wait. Start from the beginning. Read it, so that we know. So 54 with
lesion
present
on
with
his
forearm.
forearm, slow developing over the past 2 to 4 months, bleeds on one occasion, past medical history of Alport syndrome, renal transplant, currently takes cyclosporin, takes famipram, no DP,
This is
hypertension.
FCC, immunosuppression.
Yeah.
Yeah, that so it's good to read the question. If you look at it, you may be tempted to go for pyogenic myeloma or whatever, but then the SCC because of immunosuppression. Yeah, okay. And these are also some of the pictures. We can have a look at the pictures of SCC to help us, and it's also part of the. Look at this volcano. It's one of them we can forget, and then this one is also another one. Yeah. I think this past medicine is giving me the vibes I like for this exam.
So we're writing it in January.
I don't know yet. Let's continue. We still have some days to book
by
it.
the end of December, we should have finished past medicine.
Exactly, you get me.
That's my
Finish it
own
with
goal.
reading. If we're able to finish it with reading, I'll comfortably go and write it because I will now start gathering extra
Then
info and
January
revise
is
it.
just to now
Yes,
recall
you know my
and
target. Although for your own is better, you know you are doing less than full time. You have more time. Me now, I don't go carry all the activity. Think they all the lecture. Then there's this literature. There's literature review. They gave me a link. I won't even answer them. I'll just leave it there. Let's continue. I beg.
72-year-old woman diagnosed with a number of erythematous rough lesions on the back of her hands. A diagnosis of actinic keratosis. What's the most appropriate treatment? Reassurance, urgent referral, topical fluorouracil within 3 months, topical Betnovate.
So for actinic keratosis, Shebi we used to give them fluorouracil, ba?
Yeah, but I'm just thinking, are we meant to give it to them or we refer?
Or we refer. Let's
Because
see.
they asked for appropriate, they didn't ask for first line. Oh, still topical.
Yeah,
Okay.
we'll still give it to them. So
So the correct answer is topical. Are rough, scaly patches on the skin caused by excessive exposure to the sun. Is there anything here? Topical fluorouracil is first line. Medication works by. All right, there's nothing here. Let me see that urgent referral. It's not necessary unless there's a suspicion of a malignant transformation or if your initial treatment fails. All right,
okay,
fair enough.
so for actinic keratosis, we still give them fluorouracil. So look at it here. Small cross T scale, we know that one. Prevention of further attack, avoid sun exposure, then fluorouracil. Yes, I know. I saw after the first line, the next line in my imagination was that fluorouracil. That was why I tried it. And after fluorouracil, diclofenac, then imiquimod, then cryotherapy can be used, curettage and cartridge. So fluorouracil will be the first thing. This is the typical pyoderma, isn't it?
Yeah.
So and that, what is it
And it's not even
associated
part
with?
of the option.
Yeah, which of the
Okay, which
following
of the following
conditions
is
are
associated
associated?
with it?
So rheumatoid arthritis, sarcoidosis,
Ah,
virus, TB. Is it rheumatoid or sarcoidosis? Which one?
I will go with rheumatoid just
You
because
go
it's associated with IBD.
IBD, right? Yeah, and it's correct. Many people went for sarcoidosis. Did you see? That's the two option. Confusing. So let's go for the causes. That's what we should revise. Causes of pyoderma gangrenosum, and then look at through the pictures. So let's see, because we failed, so it's more dirty. Yeah, like the other picture we failed. It's more like more this thing.
No,
Then the
this one looks,
causes.
this one does not look bad.
Yeah. Yeah, one of them doesn't look back, which was why I felt the other one was. So what are the causes? Let's see. Idiopathic in 50%. IBD, yeah, 10 to 15%. And you said, so how did you say that? Why did you say that rheumatoid is associated with IBD? Why? How did you code that one? Because you
Because
mentioned
you're all usually on this auto kind of immune kind of thing together.
autoimmune, yes, immune system, yeah, so selective and yeah. Then rheumatological, rheumatoid and SLE, yeah, rheumatoid and SLE. Then hematological, myeloproliferative disorders, lymphoma, myeloproliferative
Mm.
disorders, lymphoma,
My
myeloleukamia.
sarcoidosis is not even there.
Then sarcoidosis is not there. So
Mm.
myeloproliferative disorder, lymphoma, myeloleukamia, and monoclonal gammopathy, granulomatosis with polyangiitis, and primary biliary cirrhosis. Okay, oh, we go there alright at last. Yeah, this is polymorphic eruption of pregnancy. Anyhow, we didn't take do am. But let them not come and ask us
Wait,
treatment.
that I don't this polymorphic no one stick to my head though. Is it sparing the umbilicus now? Be with
Yes,
them
it's
because this
sparing
one
it
now.
now. Look at the umbilicus is spared. It's just around it.
This one is spared this one like this.
Yes,
It
it's
don't they
spared.
chop the umbilicus
No,
now.
no shop am. It's around it. It's still spared. Look at how ugly the regions around it, and that place is
Is
just
there a
spared.
picture of the one that has the umbilicus joined
Covered.
together?
Look at it here.
Okay.
Okay.
Me
So,
get better, me get this kind of thing.
as in, then let me see. The treatment is what I wanted us to have a look, because sometimes they will bring this picture, and they will not now ask you. They will not ask you treatment and confuse your destiny. So the treatment is usually for pemphigoid,
Steroids.
oral corticosteroid are required. For polymorphic erection, pruritic condition, second management depends on severity. Emollient,
Is
mild
this steroids?
potency, topical steroid. So for the pemphigoid, the oral steroid are the mainstay, but for the pruritic eruption, emollient first line, mild topical. Pruritic eruption is just like managed in the way that eczema is managed. Emollient, then
Mm.
mild potent topical corticosteroid, then oral may now be used. Okay.
So each one of the following is associated with cysticism
Mm-hmm.
except porphyria, congenital adrenal hyperplasia, PCOS, adrenal tumor, and Cushing syndrome.
We said porphyria. Okay,
I
we
think
said
it was
porphyria is
there.
hirsutism. Yeah, so we said it's
Yeah,
hirsutism because
porphyria is
the other
there.
one was asking of alopecia, isn't it? Then congenital adrenal will have some hair. PCOS will have some hair. Adrenal tumor and the Cushing is one of them. Cushing causes
Yeah,
hirsutism, doesn't it?
I think it does. Maybe adrenal tumor.
Ah, is that porphyria?
It's porphyria.
It was it? I don't know. Hi, these things
What
that
did you read there? Was
I
it
don't even know. I
alopecia?
thought we were reading alopecia that time. So that what
Okay,
you
it's
thought too.
hypertrichosis.
Mm.
I know it said hypertrichosis, but I'm not wondering. I thought it was the same thing. But what did they say here?
Is it what did they say where?
It causes no, like what's the answer here? So it's a type of porphyria group that affects the nervous system. It is
My
primarily characterized by photosensitivity.
mm,
Yeah, we know that one. Increased hair growth on the skin may occur, but it's not hirsutism, which is male pattern. Okay.
okay.
To be honest, I know they said hypertrichosis, right? But in my mind, I felt that hypertrichosis and
It's
hirsutism are
also
the
hair
same
citizen.
thing.
So increased hair growth on the skin may occur with porphyria, but then
So
it's
it's different
not hair
from
citizen.
hirsutism. Yeah.
Okay, the congenital is associated with hirsutism. PCOS is associated with hirsutism. Adrenal tumor can lead to hirsutism if you produce excess amount of androgen. And Cushing's has a erroneously marked as not being associated with hirsutism. Has been erroneously marked. Cushing syndrome results from prolonged exposure to high level of cortisol hormone produced by adrenal gland. Excess cortisol can sometimes stimulate hair growth, leading to hirsutism. Okay, so
Which of the following skin condition is not associated with diabetes? Necrogranuloma, vitiligo, which one is? I don't even know what. I know necrobiosis is the granuloma. Oh yeah, now. What is sweet syndrome?
now that's I thought sweet diabetes sweet. That's that's why I left. That's why I left it. I didn't know what it is, but I was
And I'm
like
sure a lot of people go for it.
sweet syndrome. Oh my god.
See now, 57%.
Yes, sweet
The correct answer is sweet syndrome, as this condition is not typically associated with diabetes. Sweet syndrome is also known as acute febrile neutrophilic dermatosis. Tender erythematous plaque and often accompanied by fever and neutropenia. it is commonly associated with malignancy, inflammatory bowel medications, but not with diabetes. Now, wow.
But let us be very frank with ourselves. If there's anything called sweet syndrome, as common as diabetes is, would we not have seen it? That's what we are saying about that really, that ruling out. So that means granuloma annulare is associated with diabetes. Necrobiopsy we know, vitiligo and liver atrophy we all know. So necrobiopsy is incorrect because well-established cutaneous manifestation of DM. Granuloma is incorrect, known association with DM, particularly in its generalized form, and it presents as a flesh color to erythematous annular. Vitiligo is incorrect, recognized association with DM. Lipoatrophy is incorrect, recognized
Yeah, that
complication
one's
of DM.
wasted.
Okay. Oh my God.
What's this one on this one sleep
This
now?
Venus Lake. That's a
Eh?
Venus Lake. Look at
What
it.
is that?
It's Venus Lake, just from the way the name sound. It's a kind
So
of
it's known as, I've never heard of that in my life. Phlegmatia. It's a dilated venue that appears as a dark blue or purple lesion on the lips, ear, face. The image is a solitary well-defined lesion which is characteristic of Venus Lake. It's in elderly and it's caused by, so it's long-term sun exposure.
exposure.
Oh, wow.
Yeah. No, I went through that
Alright.
one before exam. I wish it's all these ones they brought. I wouldn't have failed.
But
They
where
were.
did you see the Venus Lake
Oh, is it the reading?
for the exam?
See, before my exam, I went through some pictures in PCDS. So, like, now, maybe when you read, you see up.
How come and you said the pictures they still brought to the exam was still out
My
of this
dear,
world? Where they
GP.
can't bring their pictures from?
It's not easy to study from head to toe. That is the honest truth. We need to agree on what we agree to do. Study the entire human being and then be like an expert in it is not easy. That's what I take it.
But for the exam purpose, I think at least if you, with the way you studied at least this dermatology, it was still okay.
My dear,
For
spiritual power.
a normal person.
Spiritual power for many, and also the cutoff is very high. So there are other areas I was weak too. I think
And maybe not the
dermatology.
dermatology part.
They're not really dermatology. I may not have done too bad actually, but the only thing I know will confuse me in that dermatology is that widespread picture I told you, and the one the open hand. I don't know what I chose in that one.
Which
And
was
then
widespread.
I told you there was one widespread picture that was at the back. Olapo, let's continue. We'll still read this now. Let's continue. If I see that picture, I'll let you know.
Okay.
Let's continue, Jare.
40-year-old man having tinea capitis, scalp scrapings, blocked air sent forth, trichitum tonsorius. What is the most management? Oral terbinafine with topical ketoconazole shampoo, oral ticonazole with topical shampoo, refer to dermatologist, topical ketoconazole. I think it's
So how old is the person? 40, right? 40, ba?
We need to give oral.
Oral
Yeah.
terbinafine.
Why
Suspected.
not just use shampoo alone?
I never hear say would they use shampoo alone for tinea capitis. I never hear them.
All right.
Well, let's try it now. Topical ketoconazole.
No. Let's follow you, not me.
Is it that what I'm even thinking? Is it oral terbinafine or itraconazole? Is there any reason for any of them?
The triconazole is usually one that is more serious.
There are many people who went for that one you wanted to choose. Terbinafine with topical ketoconazole.
Shampoo for the first. It's caused by this. It's not. Therefore, systemic treatment is required. Okay, according to UK, it's the first line treatment of tinea caused by trichomonas tonsorius. Action of topical and fungal steroids to reduce the spore. Okay, all right. Thank you.
So in addition to the topical anti-fung,
Into your eyes. Calm down.
reduce the shedding.
I'm coming.
Okay.
Let me see. Don't use the same clothes again. You need to step up this clothes. All right.
Is she okay though?
Yeah. Let's continue. 36-year-old woman 4 weeks ago with itchy dry skin on her arms, atopic eczema. She was prescribed Hydrocort with emollient. There's been no improvement. What's the next step alongside continuing regular use of the emollient?
Sorry, the temperature has changed, so my throat is itching. I didn't even hear what you read. What was happening to her?
So she has eczema. and she's already on steroids and emollient, but it's very mild steroid. It's not working, so we need to increase it.
Yeah. Let's give her the potent one. Betamethasone.
What of the moderate one? Are we jumping to
Yeah, let's give her the moderate one. The clobetasone butyrate.
which one?
The butyrate is the moderate one there.
What of the petmetazole?
Betamethasone variate is potent.
Okay.
That's the potent. But what I'm saying, how widespread is it? 4 weeks ago, with itchy dry skin on arms.
Just in the arm.
In the arm, yeah. So moderate will be fine. Yeah. Moderate is clobetasone, you see, butyrate. That variate 0.1 is the variate 0.0 something 25 that is
25, that is moderate.
So look at it here, you can revise it. So hydrocor 0.5 to 2.5 is mild, betamethasone variate 0.025, that is the betnovate RD is moderate, while clobetasone butyrate 0.05 Umovate, yeah, which is the one we went for. Potent is fluticasone propionate and betamethasone variate 0.1, and very potent is clobetasone propionate Demovate.
So 29-year-old man, GP surgery, 7-month history of focal rash. She wears sunscreen, avoids makeup, but she thinks this makes the rash worse. So tried some over-the-counter hydrocort, which didn't improve the rash. When you examine, she has dry, eccriform eruption of clusters of erythematous papules and vesicles located around the nose and the mouth. The rest of her cheeks and forehead appear clear. What's the first line treatment? Betnovate, Toxi, Imovate, Imiquimod, isotretinoin.
What are we even dealing with to start with?
So she said she has got this facial rash for several months. And she has tried hydrocort, it's not working. Acneiform eruption of clusters and vesicles located around the nose and the mouth. Read this one now. Acneiform is just, and they just said just the nose and the mouth. So it can't be perioral dermatitis now. No.
Is there anyone in the mouth though? Vesicles. My dear, let's choose the odd one there.
You try. And it's perioral.
It's still the perioral dermatitis, and that is the odd one. So what makes the skin appears dry, acneiform eruption of clusters of erythematous papules and vesicles located around the nose and mouth. Okay.
I thought perioral dermatitis is steroid that causes it, but
steroid worsens it.
Even before the steroid,
steroid worsens it.
It worsens it, not that it causes it.
So the perioral dermatitis is a condition typically seen in women aged 20 to 45, and topical corticosteroids and to a lesser extent inhaled corticosteroids are often implicated in development. Clustered erythematous papulovesicles and papulopustules, most commonly in the perioral region, but also appear in the perinasal and periocular region. Skin immediately adjacent to vermilion border of the lip is typically scared. Let's see that question again.